contraction of the peroneus longus. But because of neuropathy, an ill-timed contraction of the peroneus longus or inadequate contraction of the peroneus longus allows the first ray to stay in dorsiflexion and thereby preventing the sliding of the PPX over the first ray. This causes a jamming of the first ray. So this is another mechanism where inadequate peroneus longus function causes a hallux limitus. So this can be corrected by a KIER arthroplasty. So a KIER arthroplasty is an operation nearly a century old. It was initially described for correction of hallux valgus. So what we do here is excise the base of the PPX so that all of the intrinsic insertions to the great toe are removed and the great toe becomes, the first MTP joint becomes a pseudoarthrosis and the mobility of the great toe during the final phases of gait is restored. As I said, a small word about tip ulcers or ulcers on the great toe that occur beyond the IP joint. So these are mainly because of the mallet-like deformity of the IP joint, because of the loss of the intrinsic muscles, resulting in a claw or mallet deformity and unregulated or unopposed extrinsic contracture of the flexors. So this results in a check rein-like effect, causing the DPX to flex and stay flexed. And if you see this person walking, you'll notice that with each step, this check rein-like effect prevents the dorsiflexion of the first ray. So again, it causes a contraction and also prevents a dorsiflexion of the first MTP joint. So this also causes a high amount of axial and shear pressure on the tip of the toe, resulting in an ulcer. And this can be corrected very easily by just doing a tenotomy of the FHL. So the next ulcer we come to is the forefoot ulcers. The forefoot ulcers are very closely related to the tension in the posterior muscles. So they usually occur because of a structural or dynamic functional equinus contracture of the ankle. So as you know, when the ankle moves, that is during the first tibial rocker or the tibial rocker mechanism, the leg moves across the foot, across the fixed foot. The foot moves from a position of plantar flexion to dorsiflexion. This occurs passively because of the movement of the center of gravity and momentum of the body. This is not an active movement. So what happens here is, to allow that movement, there must be an eccentric contraction of the gastrocsoleus muscles. So if this eccentric contraction and relaxation is not enough, then what happens is there is a tightness of the Achilles tendon and gastrocsoleus unit. This results in what we call a equinus contracture. An equinus contracture causes a very high stress on the forefoot. So this happens when there is inadequate relaxation of the posterior muscles. So when there is inadequate relaxation of the posterior muscles and the foot moves from plantar flexion to dorsiflexion, there is a tightness. It causes a very high pressure on the forefoot, resulting in forefoot ulcers. These ulcers, when there is an equinus contracture, you can do either a gastrocsoleus recession or an Achilles tendon lengthening to reduce the stress on the forefoot. Apart from doing an equinus contracture release, you can also combine it with a distal metatarsal osteotomy, usually a plantar oblique osteotomy, to allow elevation of any depressed metatarsal. So this, if you ask me, if you say equinus contracture affects all the metatarsals, why is the second or third metatarsal alone getting an ulcer? It is because the second and third metatarsals are the most fixed metatarsals, and when you walk, the pressure is mostly concentrated on the second and third metatarsals. If the foot has an inverted or reverted stance, then you will get a border ulcer, which may be a fifth metatarsal head ulcer or a first metatarsal head ulcer. So next, coming to the plantar midfoot. A midfoot ulcer is usually due to a structural collapse of the foot. It can occur because of midfoot disruption or collapse, or an Achilles tendon failure sometimes. So a lever failure, this is what occurs in a midfoot collapse. So as we said, see, the foot acts as a class 2 lever, where the fulcrum is in the MTP joint and the effort is in the Achilles tendon and the load is on the talus. So when there is a midfoot break, that is, the lever itself breaks, what happens is a fulcrum shift happens. So when this fulcrum shift happens, because of an arch collapse, what happens is the pressure gets entirely transmitted. There is a dislocation between the forefoot and the hindfoot and midfoot unit as the structure, as units. So because of this, you can see there is a relative plantar flexion of the hindfoot and midfoot, whereas a forefoot moves into dorsiflexion. This is what results in the rocket bottom shape of the midfoot collapse. So here what happens is, instead of the pressure going to the forefoot as in this normal forefoot, in the foot where there is a collapse, the pressure moves to the midfoot. So this results in a midfoot ulcer. So how do you identify early collapses? What you can do is you can take weight-bearing lateral x-rays, and if you draw a line through the first metatarsal, it always coincides with the long axis of the talus. Whereas in a foot with collapse, you will notice that the long axis of the talus makes an angle with the first ray. And depending on this angle, it can be either a severe, mild, or moderate deformity. So this is about midfoot ulcers. And another difficult ulcer, which is the plantar heel ulcer, the mechanics are mainly because of the loss of the effort required to lift the tibia or do a heel off. So plantar heel ulcers, in other words, non-infected trophic ulcers of the heel, are mainly because of a loss of the effort on the effort side. So the effort, in other words, the Achilles tendon mechanism. It can be either a paralysis, it can be an Achilles tendon rupture, or it can be a type 3B fracture of the calcaneum, where the entire enthesis of the Achilles tendon and calcaneum come off posteriorly. So anything that disrupts the continuity of the gastrocnemius, soleus, Achilles tendon, calcaneum, midfoot, anything that disrupts this mechanism will result in the foot collapsing backwards, resulting in what we call a calcaneal gait. In other words, a prolonged contact of the heel during the entire duration of the stance phase. It results in a calcaneal gait. And this you can see exactly like in a wheelbarrow. If the effort fails, the whole wheelbarrow tends to collapse backwards, resulting in a high pressure on the heel, which reflects as a heel ulcer. So whenever you put a patient on a heel ulcer on a pedobarogram, you'll notice that there is nearly absent, no or very little loading on the forefoot. In some patients, you may get a first metatarsal load alone, but that is due to the peroneus longus rather than the Achilles tendon, and as a secondary flexor, it is not enough. And if you see, all patients with heel ulcers will nearly always have a contraction of the toes because they have a hyperactive secondary flexor action. The secondary flexors include the long flexors to the toes, which is the FHL, FDL, and the peroneus longus. So all of these may cause high pressure areas, but this is inadequate to offload the heel, resulting in a heel ulcer, which requires reconstruction as per the site of failure. So if the Achilles tendon is lost, if there is a big gap, you need to do a reconstruction. If there is a small gap, you can do a primary repair. If there is a very big gap that or with a loss of enthesis, then you need to recreate the enthesis with a tendon transfer like an FHL transfer. But all of these, do these patients really get back their load bearing capacity? Yes, this was a patient who underwent a FHL transfer. You'll notice that there is a relative wasting of the gastrocnemius and soleus muscles, but he is able to do a single leg raise on the reconstructed leg also. So this is the ultimate test to test whether your repair has been good. You have to do a single leg raise on the affected foot. If the patient is able to do it, then his Achilles tendon reconstruction is good. If he is not able to do it, the Achilles tendon is not working or the reconstruction is not adequate. So, for example, as plastic surgeons, our immediate response to any wound is to put a flap on it or put a graft on it. So we just did that in this patient. You see he has come with a heel ulcer, a non-healing wound over here. We put a gracilis, but if you notice that his entire calcaneum is destroyed and what little residue is left is again moved upwards because of the Achilles tendon shortening, an adaptive shortening of the Achilles tendon. And this person, despite putting a flap, he comes back with an ulcer. So what do we need to do? We need to fuse the ankle. So you fuse the ankle and then the ulcer heals. And if you notice that he will be able to walk only on the forefoot without putting the heel on the ground. So this results in a good healing of the ulcer. So I have not covered the entire spectrum. In the given time, I've tried to cover the most important of ulcers. And thank you, Dr. Pavan, for giving me this opportunity. So I think I'll stop sharing my screen with this. Thank you once again. And just a minute.
Thank you, Dr. Madhu. I am so grateful that you could take time out from your busy schedule and address us. I do agree that we had some difficult times in the last 2 years, but we would definitely expect you to be here in person the next time we call you. Voice. Lag.
I think Dr. Sanjay is also angry with me, not able to come over there. He's been calling me for 2 years. One reason or the other, something else goes off.
Definitely. Thank you again once again. Thank you so much for all your cooperation. And we'll make sure that when we come down, we get all your mementos with us. Sure. A collective mementos that we are collecting for you.
Thank you. And I'll just make a small announcement. On June 18 and 19, we have our Ganga live surgical workshop. We're planning it. This is the first forum which I'm telling it to. We have not yet come out with the announcement, but it's on June 18 and 19. We have a live surgical workshop. Please do encourage your students to attend it. Pavan, Dr. Sanjay, and the IPA group, please do have a look at it. I'll be sharing, putting out the brochure soon. Thank you, Pavan. Thank you for the opportunity.
Thank you, sir. We'll not miss it for the world. Thank you so much.
Thank you.
So we'll be breaking for lunch now. I know we are behind, but we will try to join back by 2 o'clock sharp so that we can finish the other sessions. Believe me, other sessions are equally wonderful. We have Paul Graham from Australia joining us to talk about biomechanics. We have Dr. Reginald, a plastic surgeon from Hyderabad, sharing about his cases. So we'll finish quick lunch and be back here by 2 o'clock. Thank you. नहीं वो मेरा Reginald for his talk next. I'm sorry we have delayed you. Please forgive us.
Hello to everybody. My respects to the legends who are present here, elders, seniors, and my good wishes to each and everyone. I'm privileged to be part of this particular meet. I thank all the organizers and more particularly Pawan, who's been taking active part here. And also thank Dr. A.P.S. Suri, the president of IPA, who's also a legend. He's working on tirelessly. I am Dr. Reginald. I'm a consultant surgeon. I'm based in Hyderabad. My place is Satyaveda Medical Center. I'm the General Secretary of IPA of the twin states, Telugu speaking states, Andhra and Telangana. Can I? Yeah, my disclosure is I have no conflict of interest and there's no monetary benefits, anything related to my presentation. I'm just here to present, that's it. Well, I'm presenting our experiences with microdacin. What is microdacin? Microdacin is a wound care solution which is having 4 constituents to it. One is a superoxidized water, sodium chloride, that is about 0.022%, and hypochlorous acid, which is 0.04%, and sodium hypochlorite, which is 0.004%. What makes this particular solution special? The way it is technically manufactured is what makes it an unique product. In sense, the technology which is used here is microcin technology, which is not been used anywhere else. Only this particular product has this particular technology, and this technology is based on the electrolysis process. It took about nearly 20 years for the microcin technology to advance and to get stable hypochlorous acid. Hypochlorous acid out of the body is not that stable, but they have made it quite stable. And this technology also makes this a safe pH, that is nearly pH neutral is what is being maintained. See, and this particular technology is available. This particular product is available everywhere in the world. It is a patent and technology. It's an FDA approved. It is US EPA approved. And it is one of the things which mimics the body immune system. What is so special about this hypochlorous acid and then sodium hypochlorite? If at all we go back to our MBBS days, we've been taught about Diakin solution, which has been there for hundreds of years as a wound care solution. The Diakin solution is nothing but sodium hypochlorite. Now, other than Diakin solution, a better formulation with hypochlorous acid has come up. This hypochlorous acid, which is much stable outside the body, is what we are going to use. Why are we bragging about hypochlorite solution? We'll understand this. The 2 bioactive substances are hypochlorite acid and sodium chloride. And why we talk all these things is we need to understand the wound. Again, getting back to our pathology, the wound, infected pathogens are there. What initially happens is the neutrophils are the one which seep out either from the vessels or from the tissues nearby, and then they come into the engulf the pathogens. After they engulf, they kill the pathogen. How do they kill? There's a pathway which says the oxidative burst pathway. This is the one which is responsible to kill the pathogens. This is what happens in our body. What happens is once the neutrophil takes over the pathogen, the water and oxygen in the presence of NADPH are converted into peroxide and further are converted into hypochlorous acid. And it is this hypochlorous acid which is what kills the pathogens in our body. This particular hypochlorous acid is what is also present in this particular solution. So what we are trying to do is, if at all there is an infection, along with the body immunity working for the wound, we are also helping it to further better by providing even from external hypochlorite solution. Are there no other companies with this particular solution? There are companies with similar solutions, but what is so distinct about this particular thing is the stability of this compound. Because it is stable enough, it works well. And the uniqueness of this compound is it is more pH balanced. That's why it works well. If it is too acidic, because it's an acid, if it's too acidic, I don't think it can do any benefit to the body. If hypochlorous acid is not used properly, it can damage the tissues also. It can be an anti-inflammatory, or it can also be an inflammatory, it can become a part of inflammatory process also. So that is where the stability of hypochlorous acid is very important, and this is how hypochlorous acid is seen. Now, this particular solution has hypochlorous acid, sodium hypochlorite, and also high levels of oxidation solution there, which act on the cell walls and disrupt the cell wall, and then there will be death of this particular pathogen. Which all pathogens are it is able to work upon? Well, it is able to work upon all sorts of bacteria, both gram-negative, gram-positive, and spores, viruses, yeasts, and molds. That means the spectrum over which it can act is wide. It's a wide spectrum solution where things can really help us. And getting back to microdosins pathogen kill time, that is, if at all a pathogen is there and if we expose this particular microdosin to that pathogen in a given time period, what is the effect on it? If at all we see MRSA, Staph aureus, or Candida, or Klebsiella, or Pseudomonas, or influenza, or pneumonia, when they are exposed to this microdosin for about 30 seconds in vitro, nearly 99.99% are killed. That is the specialty of this particular solution. And other than just killing the pathogens, there is another important thing is everybody knows what is biofilm. When there is biofilm, it's most of the time, even the topical antiseptic or lotions, what we use, they don't act in the wound. But then this particular microdosin penetrates through the biofilm. You can see in the picture, the green is the one with the biofilm and the living microbes. Once this particular solution is used, by using a fluorescence microscopy, we are able to see most of the pathogens are dead. So it's a win-win situation that even through biofilms, we are able to treat the pathogens and also able to also kill the pathogens at the same time. Other than this, what are the other things microdosing can do? It can do inflammation control. That's what I told you. Hypochlorous acid can control inflammation or it can deteriorate inflammation. Provided it is stable, it will be able to control. And it can also stimulate wound healing. We have already seen what is infection control. How does it cause? Okay, increased oxygen is because of the oxidation which is happening there. These are some of the graphs which are being told and how the basic wounds are being healed. Let me talk about inflammation. When we see about inflammation, Fukuyama T et al. They have come up with a trial and they have concluded that this particular solution reduces itching, pruritus, and also inflammation in vivo. So patients who have wounds and surrounding areas which are having pruritus, this is where it can really work good. So this is what happens. Microdosing basically blocks the mast cells activation without causing toxic effects. It does not cause toxic effects, but blocks the mast cell activation. Then this is what is again further happening. It inhibits about 86% of the release of the histamine. That is the reason where it is also sometimes anti-allergic and this pruritus is reduced. Inhibition of the secretion of pro-inflammatory molecules. It inhibits mast cell degranulation. So the inflammation is very much subside. Once we start putting it on the wound, you start seeing the results in about 24 to 48 hours. You really appreciate and notice them. This is what I did in my clinic too. Well, as I said, hypochlorous acid is an anti-inflammatory agent, provided it is a stable compound. Then, as far as pruritus is concerned, it has been also seen in a trial that 50% have immediately reported betterment in the pruritus, that is the itching on day one itself, and about 85% have also shown betterment after about 3 to 4 days. That's clinically proved. How does it help in wound healing? How does it stimulate wound healing process? The first one is it removes the pathogen, it penetrates the biofilm, it decreases the inflammation, it is anti-allergic, it is anti-pruritus. These are the 5 things which we have seen. Added to that, it is also going to help us in wound healing. How does it help us in wound healing? Sakaria S et al., who did a trials and have published in Wounds Journal in the year 2014, have come up and said this particular solution is favorable, has favorable effects on fibroblast and keratinocyte migration. So what exactly happened? There is a wound where you put this particular solution. You can see in the extreme side of the screen, there is a recruitment of fibroblasts. This fibroblast increases the collagen production. The collagen itself is a healing factor which helps in the wound to heal better. So this particular solution also helps in wound healing. All right, there's a randomized control trial done by A. Piagesis et al. It's an international and published in International Journal of Lower Extremity Wounds in the year 2010. They have concluded that this has a wound healing time is significantly less because of the collagen which is being formed. They also said that the reinfections were slightly fewer because it is acting through the biofilms and also onto the pathogens. And the duration of antibiotic therapy is significantly shorter. Instead of giving about 2 weeks, 3 weeks, or 4 weeks of antibiotic therapy, using this locally helps us to reduce the antibiotic treatment given to the patient. Yeah, and another randomized control trial also has come up which says that there is a reduction of bacterial load, that exactly what happens when the pathogens are killed, and the healing time and skin reactions. This is where the allergic reactions and pruritus are also there. They all reduce. What is the advantage of this particular thing? It can be used to clean. It helps in debriding. It helps in disinfection. It helps in granulation and epithelialization also. This is basic way how it is being used there. I'm not dwelling into it. That's how they do it. There's also a solution and also a gel. Some of the case studies which we have seen is this particular case, which is having a scald burn oil. Basically, oil penetrates the skin and the burns go much deeper than water. But then this again, this girl, post third day with the treatment with only microdacin, has shown much improvement with this particular treatment. And this is something important. Pseudomonas is also treated. The Pseudomonas here with the necrotizing fasciitis was been treated, and of course it took a bit longer to treat. It's 41 days, but the wound is ready for grafting. There is a little bit of contracture, a little bit of fibrosis there. Maybe during surgery it can be attended to, and it is ready for graft. Then the same thing again, lymphedema cases. Of course, the granulation is not that healthy over here, which can be taken care of much better. But you can see the change of the first day and later on as the days have been progressed. Basically, the slough is gone and good amount of granulation has come up. Then this is another important thing: ischemic ulcers. Ischemic ulcers, we really don't know what is to be done. Sometimes we just leave it. We keep watching them what to happen. Sometimes patient won't be able to afford vascular surgeries, or they won't be able to afford the plasties what they are being done in the vessels. Sometimes these people may not be able to afford the stem cells or the other treatments which have to be done for improvement of the thing. So end of the day, what we do, we wait for that line of demarcation and all that stuff, and we go ahead with the amputation. But this is where again it can help. See, same thing, post debridement of a diabetic foot, and again a trophic ulcer. Of course, here an offloading has been given. Without offloading, you just don't continue to do your dressing and don't expect any results. The offloading is very prime because it's a trophic ulcer. It's offloaded and then this has closed up. Same thing again to amputation. Plantar surface things, the healing is quite good. This is post-cellulitis foot ulcer. Now it is ready for graft. This is something important, particularly in rehabs and elderly people where they have bed sores. See, the initial picture shows us slough and unhealthy granulation. The later picture shows a better wound. This is again a ischemic toe. Thank you. But before I end, this I don't promise you that this solution is the one which is going to be the god of all. It's the doctor who's going to be the decision maker. It is his expertise, his understanding of the wound, and his methodology of work which helps. And this is one of our armamentarium, which is going to be good for us if at all we use it timely and properly. Thank you.
Thank you, sir. Can I ask Dr. Chalnarayan sir to hand over a memento to Dr. Reginald? He has taken time today from a very important personal function to come and address us here. Thank you, Dr. Reginald. Next, we have Dr. Tushar, all the way from Bombay. Thank you so much, sir, for agreeing to come down in these difficult times. And yes, we have spoken about the clinical aspects, what are the dressings, what are the biomechanics, but we rarely do come to know about the socio-economic impact that a diabetic foot ulcer or a diabetic foot disease has on its patient. So it is absolutely imperative that someone tells us what is the impact in India. We have so much of data across. We have so much of data, the Western data, but very rarely do we get data in India. So it is necessary that we understand what are the socioeconomic impacts that these things are having. Over to you, sir.
Mahesh. Good afternoon, everybody. It's a post-lunch session, and post-lunch sessions are not very conducive to anything. But Firbi, I think seeing so many people itself is a good thing. I shall be talking about a general thing, and that is socio-economic impact of diabetic foot in India. When this topic was given to me, we hardly have any data. And when we open textbooks, this is the first time I'm speaking on diabetic foot implications in India. And when we opened books, there was only American data, the US data. And believe me, the thing which I found here was that for a major amputation, it takes about 64,265 US dollars. And that really made us frown. I showed my own eyes frowning at such a figure. Can you imagine this? And then started calculating as to how much that amount comes to. And believe me, it comes to about 50 lakh rupees for a major amputation. Now, this is the US data which we have. Then we started searching our own data. There is no registry which can tell us the economic implications of diabetic foot in our country. So then what did we do? I had this patient. This is a wound full of maggots. What do you think could be a reason that this patient did not come to me or any other center in Mumbai for treatment? This was a patient, this has not happened overnight. This is gangrene, completely dark black foot. What precluded this patient from coming to a clinic? And this was another patient with necrotizing fasciitis where the entire leg had to be debrided. What precluded these patients from coming to either a specialty or any clinic? And the reason being, there is a vast range. I'm talking of Mumbai for the time being because I could not find data all over the country. And we have high rises on one thing. On the other end is extreme poverty, where this is literally a walk through a small slum, a dingy walk, where getting a diabetic foot patient from his home to a taxi itself is so difficult. So this is the range what we are seeing. Plush high-rise buildings to dingy walks where a patient cannot even be transported from one place to the other. And that made us thinking, this is the study and this is the statistics we are talking of, which speaker after speaker has spoken. About 90 million diabetics, we talk of 100 million diabetics now, and there are about a double number of feet or people at risk. So who is going to take care of this diabetic foot burden? More than 1 lakh amputations, a large thing could be avoided. But at the same time, when we are talking of a theme of IPA, I prevent amputation, there are stark realities. And what are the stark realities? I'm seeing one patient over here. Is there a volume over here? It's okay, fine. Just to tell you, on one side, we had a patient with extensive necrotizing fasciitis. The theme is to save the feet, save the legs. Every person is going to tell us also to not amputate. And this is what has happened. On one hand, we have a patient with extensive necrosis, tried to salvage. The foot and the leg could be salvaged. And here is the person who is walking. This patient could ultimately climb stairs. He could get down the stairs and the foot or the leg is salvaged. On the other hand, we have another patient. Sorry, something wrong with the slides, I think. Sorry, in this I wanted to show on that other side that there is a patient who could walk. A similar time, another patient comes with necrotizing fasciitis. Neither could she walk. Ultimately, this lady died. Now that's somehow that video is not coming in place. So where is the drawing line when it comes to the economic burden for all such patients? And then at the end of it, what do we get? And what are these figures? In a corporate place like Mumbai, these are the bills which are coming to patients: 4,60,000, 1,30,000, 1,28,000, and ultimately to give them just a walking foot, this amount, whether it is justifiable, because we have a huge spectrum of people which vary from slum dwellers to people living in plush societies. Again, the range is, at one time, there are people who have wonderful access to double bars and training on below-knee amputations and the prosthesis used. Whereas, on the other hand, there are people who have to do with simple prostheses which are just given by any public hospital where, you know, there isn't silicone, that they are not a sort of customized footwear. At the end of this, again, it boils to the economic status. And therefore, we did our own study as to, I really couldn't find any specific study. In fact, sir, the only reference I found was you writing about the cost involved, Dr. Suri's article, where he has mentioned that an amputation can cost up to 10 lakh rupees. And that was, we were trying to study where we could find data. So we called about 200 patients whom we had treated from various hospitals. And here, what we find is that just the clinic cost, consultation cost from a public hospital could be anywhere from 0 to 60 rupees to a corporate hospital where one consultation becomes around 4,000 rupees. Similarly, the cost of hospitalization in a government setup could be varying from 50,000 rupees to a corporate hospital where the expenses just go haywire. I've written this cost of about 6 lakhs rupees for a major amputation. But God forbid if this patient has a renal disease, he has an ischemic disease, he lands up in the ICU, the cost escalates not just 2 times, but it could be 3 to 4 times or even more. In addition to that, the challenges are public transport is difficult, people do not get taxis, and this Kali Pili taxi in Mumbai is a big headache. Whenever you have a problem in the foot, not a single person is going to allow you in that taxi. These people keep pleading to us as to what they are supposed to do. There are incidental expenses, and in this, I keep showing this slide. This lady was my patient who was there with me for 3 months, her ulcer healed. But the heroes of this slide are not that patient. The heroes of this slide are her son and her nephew, who have been spending almost 3 months not attending their work, taking pay cuts, almost on the verge of losing jobs just because they had to accompany their mother or their aunt to a clinic. So these are the challenges which we keep facing. And therefore, since time is short, we are running behind schedule. Dr. Pawan has told me to cut as much as possible. So diabetic foot has all these implications, that one diabetic foot, but multiple social and economic implications which are in place. And with all this comes the psychological problems of a person who has to have his EMIs, his insecurity, his stresses, school fees, and that is not at all considered when a person is out of work in a diabetic foot. Now comes the thing of health insurance. I just dwell on this topic very briefly. It has been found that even in a metropolis like Mumbai, it is only 10% of the people who are covered with Mediclaim or health insurance. We keep feeling that, you know, there are a lot of insurance covered people. No, it's a very small amount. And this thing is going to increase manifold once you go to a rural setting where people pay out of pocket. By out of pocket means nobody else is going to pay for my treatment. I am going to pay for my own treatment. And then because I'd asked a statistician, because I'm poor at statistics, she made multiple slides. but I think neither will I be able to justify many of them. And thus, to save time, we skip through all these bar diagrams and diagrams which actually tell about the problems. Now, I'll just stress on one or two things. That in a developing nation like India, we have people who are paying out of pocket. Now, that is when we talk of the socio-economic burden, it is something to be remembered that people are paying out of pocket. That means every one antibiotic is a burden to me because I'm going to pay. Some of my company or insurance company is not going to pay for it. And because diabetes and diabetic foot is chronic in nature, it's going to be a huge burden because it's just like a never-ending story. And that leads to depressions in many individuals. For some time, we also had a counselor at the clinic because we really felt, but actually, how do you counsel a man who has actually lost all his money on treatment? You know, it's very nice to say, don't worry, it can be made up, but nothing of that sort actually happens. And ultimately, unfortunately, because of lack of awareness, this is something which will end up in bilateral above knee amputations, which almost has made this man's life a lifeless life. Why are we here today? What are we talking? We are talking of what is the way forward? What do we do about it? And the first thing is, one has to have a health insurance if diabetic foot is to be treated. There are a lot of insurance schemes, but the problem of insurance schemes is complications of diabetes are not covered many times in the early part of insurance coverage. It is up to all of us who are actually dealing with diabetic foot to take up with the authorities so that at least in future, these problems can be taken care of and insurance coverage at least will take the burden out up to a small extent. The other thing is, since there is no registry, I heard Karnataka chapter has a registry, but if we collate all this data and take up with the authorities, because today when I have to present the economic burden of diabetic foot, it's a skip short thing. I was only trying to see my own data, which is in a metropolis related most to corporate hospitals or nursing homes, which may be totally different from the scene all over India. So I think we have to collate all this data, take it up with the authorities so that we have authentic figures to tell them as to why the government has to interfere in this. They also found something very interesting, that out of some 69,000 hospitals surveyed, they found that 43,000 hospitals were in the private sector. Now, this again something is which I was not aware till you all gave me the opportunity to study this particular thing. So, if private setup is outnumbering the public setup for diabetic foot, it is again going to be a huge problem because today diabetes is affecting not just the affluent but everybody per se. And therefore, I was told I was going to speak before lunch, so I thought, to catch attention, I wanted to show this one video. It is not to enjoy this song, but I think this audio aa jayega. Can audio be there for this? No, its audio is not. Anyway, this video loses its steam without the audio, but this is I don't know whether you can see this. This video had gone viral. This is something, a person who has got the best of amenities in the world. But why I put it in the socio-economic thing was, this is Rakesh Jhunjhunwala. He is a person worth some 40,000 crore rupees. And those who deal in shares or stocks would realize that about 5 or 6 years ago, we were responsible because he was admitted at our institution. And there was a dip in the stock market. The stock market nosedived because he was admitted with diabetic foot. Now, he would have all the best of amenities, but just Jhunjhunwala being admitted for diabetic foot actually is a huge thing for the stock market. So there was a very nice song which maybe you all can see on this viral video on YouTube. So a lot of things here need to be covered in the sense, to be very brief now since we're running short of time, as I mentioned, that what we really need to do is have a registry, have a complete submission to the government, whereby we can either reduce cost or control cost of treatment. Corporate hospitals, those who opt for that, will actually have to be very well insured. But the most important thing is making people aware so that they go to the right places at the right time so that the problem would be taken care of. I always end my talk with this slide. We all show dirty slides, maggots, gangrene, pus, infection. I was told my talk was before lunch, so I'm showing the best legs in the world, and those are the legs of Jennifer Lopez. So diabetic foot is not too bad. You get to see some of the best legs in the world. Thank you. Thank you so much. Was there any time?
Yes. Thank you very much, sir. Is there any questions? Any quick questions? Very apt in terms of where should be the next step. The next step has to be the insurance needs to cover diabetes. Otherwise, we will not have enough money in the world to treat diabetic foot. You know, whatever, it could be Rakesh Jhunjhunwala's money or Bill Gates' money. If you put all that together also, we will not have enough money to treat the patients in the world today. Thank you very much for this. I would request Dr. Srinivas to please come on dais and facilitate. Our next talk would be from Dr. Paul Graham from Australia. He will be joining us online. Most of you have heard about, or in your own clinics, you have plantar pressure scans. Can I have a raise of hands who all have plantar pressure scans in your centers? Yeah. So how many of you really know, you can connect him. Okay. Put him online. So how many of you really know how to read a plantar pressure scan, apart from saying that this red is high pressure, this green is low pressure, and this yellow is medium pressure? Apart from this, and there is a gate line and there is a pressure line. Apart from these 5 things, how many of you know how to read a plantar pressure scan? Leaving these 5 things. Dr. Maya, I cannot, he's an authority on it, but anyone else? Any of the physicians, surgeons who can read a plantar pressure scan beyond these 5 things? So Dr. Paul is my guru in that. I have been attending his sessions online and offline. He has been an advisor to FootSecure, where he is training our whole team on how to read plantar pressure scans and what to interpret out of it, and what insoles or what footwears to be designed using plantar pressure scans. And he's going to talk about role of plantar pressure scans in diabetic foot. Welcome to Dr. Paul Graham. Well, so the dais is yours, Paul.
Thank you, Dr. Sanjay.
Volume.
Thank you, Dr. Sanjay.
Paul, we can't hear you yet.
Oh, okay.
Yeah. Can it better? Can it be a bit louder? Paul, can you speak a bit in this?
Okay.
Yes, we can hear you.
Thank you very much for the great privilege to speak to your symposium today. And I have a presentation that has been preloaded. And so perhaps we could start with that, and then we'll have a time for questions. Thank you to the tech team to start the presentation, please.
Start with the first slide. Oh, it's a video. Oh, it's a full. Right.
Between
there be any questions for Dr. Paul? While the time you think about any questions, we have one quick case study with Dr. Raj, which our orthotist Rajeshwari will be presenting. Let Paul be online, okay? And Rajeshwari, can you just finish? Can we have this screen there? Slideshow.
A very good afternoon, all the dignitaries and the delegates over here. So I am Rajeshwari, orthotist and foot secure. So today I will be presenting a case study on orthotics management and diabetic foot. So we had a patient like 60-year male with a known history of diabetes mellitus type 2. And he was also having diabetic neuropathy with callus on the plantar aspect of right fourth metatarsal head and left hallux with the hallux rigidus on the left side with right forefoot supination with bilateral pace planners. So this patient came with us with all these problems. So what we do is, as a rehabilitation team, we go for a plantar pressure scan, which Dr. Paul has already explained as you have seen this. So after the plantar pressure scan, we have some manual assessment which we do, like the orthotic pathway. In that, we have some set of assessments like the LLD, which is the limb length discrepancy, the hallux rigidus, which we check, then also the subtalar joint axis location, and also we do all the assessments which can be done according to our part. So after that, we will just do the orthotic intervention, in which the total contact orthosis with the following modifications were provided to the patient. We customize insoles. So we take the molding of the insoles, and according to that, we customize the insoles with some modifications. So with this case study, for the right foot, we have provided a medial longitudinal arch support, fourth metatarsal head offloading. As Dr. Suri also spoke about the offloading footwear and the rocker, which is like very helpful in this case. So first raise support for hallux limiters was also provided. Soft felt pad was given. Heel lift. We provide for the left foot, first raise support. The metatarsal dome was given. Medial longitudinal arch support was given, and heel lift. So we provide materials such as Poron and EVA, which can be given in case of diabetes. So this helps in a better cushioning, and with the density and the show level, we decide what the diabetic patient has to wear. According to that, he is comfortable with the material. So we customize insoles as well as footwear. Customization is done according to the patient's assessment and everything as we look into it. And also we have just put a stall over here. If anyone is like interested in this, so you can please come and join us. And if any question is there, you can come in person and ask me. I would be like to answering all your questions. Thank you.
Thank you. So any questions to Dr. Paul on the plantar pressure scans? Okay, so should we get to the next session? The next session would be the Urgo Symposium. I would request Dr. Prateek, sorry, not Dr. Prateek from Urgo to please come over the dais. Thank you, Dr. Paul, for this.
Thanks, Dr. Sanjay. I'm sure you are expecting I'm going to make a joke about how you just gave me a new degree. So thanks a lot for making me a doctor in a very short notice. But it's always glad to be here with all of you. And it's a great pleasure for Urgo Medical to be present at the KIER Diabetic Food Symposium. A big thanks to Dr. Pawan, Dr. Sanjay, Dr. Maya, Dr. Suri, and all the team of IPA Karnataka, KRSSDI, and KIER to have made this fantastic event, which I think Dr. Pawan has been talking about for a while now. We have been speaking about the possibility of having this kind of a symposium, and it gives great pleasure that Urgo Medical is one of the partners, and we will continue to be doing that. Can I get my slide deck, please? I would just like to present a few things before handing it over to the doctors for their product experience presentations. It's there? Not sure. I think it's working now. Thank you. So, no, it is. It's fine. So thanks for giving us an opportunity to present our projects, because as an organization, we are also very keen to present what we do, why we do, and we will have the expert clinicians speaking about the usage of our products right afterwards. I will let you know what we have been doing in India so far and what is our purpose of participation in this event. So over the last couple of years, I'm proud to say that we have brought some solutions in diabetic foot ulcer, both for infected diabetic foot with Urgo Clean AG in 2020, and now recently with non-infected diabetic foot with Urgo Start, the only dressing recommended by the IWGDF guidelines. First of all, when we bring a product in your hands, any person of our team is sure that it is an evidence-based product, but we want to further ratify that evidence with real-life clinical experience. So if any of you have been contacted by our team for clinical cases or clinical experiences, journals, that's because we want to ratify the RCTs, the observational studies that we have abroad with evidence that we generate in India and convert it into publications. So that's our mission for bringing innovative evidence-based medicines in India. And thanks to these efforts all over the world, particularly Urgostart, the new product that we brought into the market, it has a very high level of recognition all across the world. It is the only product recommended in the IWGDF guidelines for local care of diabetic foot, the technology being sucrose octasulfate. And it's also the only product recommended with the brand name in the NICE guidelines for advanced wound care, which recommends its use in diabetic foot ulcers and venous leg ulcers. So this is something we are quite proud of, and we hope to establish the similar level of support from Indian associations such as IPA. Sir is sitting right in front of me, so that was the first name that popped, and get that level of support from clinical bodies. So our Leading with Science is another mission, which has allowed us to publish all our data from 65,000 plus patients in some of the top journals of the world, Journal of Wound Care, Lancet Journal of Diabetes and Endocrinology. And very recently, during the last 1 year, we had 3 publications coming from Indian clinicians published in Wounds International, Journal of Wound Care, and Wounds Asia that documented the usage of Urgo medical products, Urgo Clean AG and Urgostart in particular, on chronic wound care. So one of the publications, which I think Dr. Sanjay might speak about later, is Wounds Asia Journal, where 12 clinicians from all across the country came together to contribute 24 clinical case reports. It's a great thing that 4 of them are here in this room, Dr. Srinivas, who is the lead author of this journal, Dr. Pawan, Dr. Sanjay, Dr. Amit. So I'm glad that 4 of you are here in this room to share the experience with your peers and your experience about the positive effect of Urgo Clean AG on your infected patients. And the new feather in the cap on a clinical evidence approach that we are really excited to announce is we concluded an observational study on 60 patients across 2 centers. And one of the centers is none other than KIER. So a big thanks as well as a big congrats to Dr. Pawan, Dr. Ravi and the team at KIER who has been able to complete this observational study just within a span of 3 months. So if I would actually request a round of applause for Dr. Pawan and his team for doing this. And the feedback has been very positive. We look forward to converting it into a publication. Finally, all this is not enough. A few minutes back, we saw Dr. Tushar Rege's amazing talk on socio-economic impact of diabetic foot. And we know that every 18 seconds, a limb is lost somewhere in the world as a consequence of diabetes. And as a wound care player, we ask ourselves, what if more can be done? We bring you Urgo Clean AG, we bring you Urgostart, we bring a lot, but what if more can be done? And that's where we decided to do more with Save Feet, Save Lives, which till now was restricted to a digital forum. And we brought a lot of resource structure. So we brought a lot of foot care at home literature for patients and their families. We brought some patient awareness videos with a very handsome doctor, you can see, Dr. Pawan. And this has been quite well accepted by many people who worked with us on developing awareness campaigns. So I'm very happy that Safe Fit Save Lives has really taken an impact. Till now, I was wondering, how can this be bigger? How can this be more glamorous? And I think the answer for that was brought by Dr. Sanjay Sharma with Safe Fit, Safe Ride, collaborating with Safe Fit, Save Lives. And I'm sure all of us cannot wait to see Sanjay on a motorcycle with his biker jacket and riding this bike for raising awareness in diabetic foot. So with that, I will end my small introduction. Thank you very much. And thanks, Dr. Pawan, for taking it over.
Thank you, Pratik. Nice. Good afternoon, everyone. Thank you, sir. Thank you so much. Yes, thank you, Pratik. Once again, the DFU burden and awareness. I would really like to thank Urgo. The initiatives that Urgo has taken so far has really been showing results in the past 2 years. In fact, even during the COVID time, they made some initiatives which were really, really inspiring. Yes, what can be done? What should be done? There are so many things that we can talk on, but a DFU program which is developed to support healthcare professionals in delivering optimal care for patients with diabetic foot ulceration, it should be the goal, basically. So how can we do that? You improve the organization of care, implement the best standards of care, train, educate, and raise awareness. I always keep telling them. In fact, many of you who would have come here, if you go and see my department of podiatry, we have a separate foot counseling room. That is the importance that we give to awareness, and that is the importance that everyone should give if we have to reduce the diabetic foot burden in India. Now, DFU represents a high burden for patients, HCPs, and society. Almost 1 in 4 people with diabetes will potentially develop a foot ulcer. We all know this. A foot ulcer left open for more than 30 days is 4 times more likely to get infected. Diabetes has become the #1 cause of amputation worldwide. Diabetes causes 1 amputation every 20 seconds. I keep telling Pratik, and he has put it in his presentation, not in mine. It's not 20 anymore. We are, as if you remember Dr. Saurabh, in India, we are close to 10 to 12 seconds. That's how bad it is in India. This is global data that we are talking of, every 20 seconds. In India, it has come down to 10 to 12 seconds. It's only going to increase in the future. 70%, up to 70% of amputated patients will not be alive in 5 years. We all know the mortality rate, the 5-year mortality rate for a diabetic foot ulcer disease or post-amputation is that bad. What are the key challenges regarding diabetic foot ulcerations? Lack of awareness. And this is where Indian Podiatry Association, KRSSDI, and so many of us, all the stakeholders can come together. Education, again, lack of prevention. Most importantly, the attitude, the social changes. See, it's very difficult for me to tell a diabetic patient that don't eat a sweet. But if you have to inculcate that attitude in that diabetic patient, that is very, very difficult. That is the attitudinal change that we are talking about. That is difficult. Delayed identification of patients at risk. So yes, when a patient comes in and a patient walks into your OPD, we should be able to identify the high-risk diabetic feet. Delayed referral to specialists in case of foot ulceration because of so many causes. But the most important cause is lack of awareness. So Safe Feet, Save Lives was one such initiative from Urgo through DFU prevention, early identification and referral, early identification of patients at risk or presenting as a DFU, appropriate referral of patients presenting as a complicated DFU to a multidisciplinary team, and education of patients and non-specialists, healthcare professionals on DFU. So this campaign has been endorsed by DFoot International. So this was one of the patients who visited me. I'll just play the video. It was a small awareness video which we did. Can we have video on this? Audio? Can we have audio, Mahesh? That's okay. I'll just tell you, this was a very nice gentleman. He was an automobile engineer. He came to me with a small diabetic foot ulcer. When he came to me, the foot ulcer was already infected. So ideally, we made sure that it was debrided. Patient was put on standard care. Patient unfortunately had to lose a great toe. And this is where it became a problem, because by the time COVID struck, he could not meet us. And during the COVID time, he developed another ulcer, a pressure ulcer again, which got infected, and patient had to again come back to us. So basically, this patient had to undergo multiple treatments, multiple wound debridements, dressings. But the good part was patient knew when to come the second time. The first time when he came to me, he did not know anything. That's why he lost a great toe. But the second time he knew. And when he came to me, there was no amputation that was done. And we are very happy to inform that the wounds have now healed. Patient is on a proper offloading footwear, customized, and he is doing very well. But the ordeal that the whole family had to go through, that was really bad, because at that time there was COVID. No one would touch him. No one would do the dressings. And he was struggling to get a proper nurse at home. So I'm just saying that how things are getting multiplied because of this pandemic. But again, the initiatives should not stop. And I really appreciate Urgo for that. Thank you so much.
Where is the... Okay. So when the Virgo team asked me to speak in their session, I said it has been quite a number of times we have presented cases. Quite a number of times we have discussed about diabetic foot, and you've all been hearing about the incidents and the volume and other things all through. So let's think that what we did when we went to Abu Dhabi with the Virgo team, and how was the wushu's there. And this was just an experiential talk. There's going to be there nothing to do about the incidents of diabetic foot or anything. So when it was all excited. The first time for me, it was the first time at the WWHS in Abu Dhabi, and post pandemic, it was the first trip after 2 years of sitting in Bangalore. And when we went there, it was exciting. One day before I boarded my flight, I got a mail saying that the RT-PCR is not required to enter into UAE. And they also said that the Abu Dhabi as such doesn't require one more RT-PCR. Earlier it was Dubai entry, one RT-PCR, Abu Dhabi, one more RT-PCR. So I was quite excited. I landed, didn't get into any of the RT-PCR part of it, directly checked in, went to Abu Dhabi, checked in there. And then I hear from my colleagues who were there. There was, I think Dr. Abhishek Tiwari from Delhi was there, and we have Venkat from Mumbai, and they were all chatting in the WhatsApp group that, did you download Al Hosan? I was like, what is this Al Hosan? So this is the app that was supposedly to be downloaded. And it took for all of us together, cumulatively, probably about 10 hours for us to download and register on this app. And then after registering and everything, we go in there. In the conference hall, it was mandatory for an RT-PCR. So when it was mandatory for an RT-PCR, there was a small booth, good way to make money. If you need an RT-PCR for in 1 hour, it is 500 dirhams. If you need it in 3 hours, it is 300 dirhams. If you need it next day, it is 50 dirhams. So that was how the RT-PCR was, and we had no choice. That was the opening day of the thing, we had to pay about 500 dirhams and get the RT-PCR done, all the three of us. And even then, we need a green pass. If you say how to turn green, it's like it's written there. We need a green pass for us to enter the conference. So now it is looking gray. And even today, after I came in about a month, even today it is gray. I do not know how to turn it green. And we had to figure out how to enter the conference venue with this in gray. I think incidentally, Prateek was also there, and Prateek's turned green immediately. But we as doctors, we couldn't figure out how to turn this green. But somehow, with the RT-PCR report from India, from there, everything, we entered, and we had to get an RT-PCR every 4th day. So if you see there, the first dose and all those things given, one RT-PCR below on 3rd March, another one on 1st March, and second one on 3rd March. But you would see. So every 4th day, we need to get an RT-PCR to live or stay in Abu Dhabi and Dubai. And that was, we thought how lucky we were, and how lucky Srinivas was, and how lucky Pawan was of not coming there. But you did miss some things, but this was really an example. So we had Dr. Rajesh, Dr. Venkatesh, and me and Abhishek Tiwari coming over there and doing some talks in the Urgo talk area. These are some of the pictures that we say. We have Venkateshwaran talking about Urgo Start, Dr. Abhishek Tiwari talking about Urgo Clean AG's clinical experience, and we had a complete Urgo session. I think this was the sorry, except for the plenary sessions, I think this was the only session which was jam-packed like this in the whole of the conference. This is some of the talks that we were giving in the Urgo booth itself about Urgo Clean AG, how to do the dressings. You could see my face for sure. And these are all the cases from all the regions of India that was displayed in the conference. In the Wounds Asia journal, you can pick up the paper that is there in the Urgo stall anyway. So that this you could see, we have Dr. Srinivas's cases here, Dr. Pawan's cases, Amit Jain's cases, that has all been displayed. So I don't want to get more into this. This was the case, one of the 2 cases that I had presented on behalf of Urgo. One of the cases which had a stump that was infected, which we treated with Urgo Clean, and you can see the completely healed wound on the about 30 days from the time we started Urgo Clean. And this was the other case which we had the wounds in across all the web spaces, and we can see the final review after about 30 days again. So this was my experience with Urgo Clean, and also some of the experiences with Urgo Start also going further, but I would end my presentation at this point of time. Thank you very much.
Good afternoon, everybody. Post-lunch session. Dr. Sanjay has finished it very fast, so even I'm going to finish very fast. As promised last time, we had presented in the one of the talk of Urgo, we are going to come back once our publication takes place. And this is one of the publications which we have done on Urgo Clean AG. So the rule was, are we going to have any of the next presentation where we're going to have a continuum of care, and says we are going to work out on it and give us 3 to 6 months time on the same. So this is how we went ahead with the continuum of care. One of our patients, which was there, a 59-year-old patient who was a known case of cellulitis with localized abscess and skin necrosis. Today, this is called as AJ2 of cellulitis before progressing to necrotizing fasciitis. This patient, we went ahead with the debridement. The wound was looking excellent with a regular wound care. But once the patient started coming at a later stage, we found that he developed biofilms, which is very evident in this photo you can see. And in spite of continuing a regular wound care, the patient was not showing an improvement in disappearance of the local biofilm, though the cellulitis had resolved. So we did a redebridement, and yet again, we were not able to remove the biofilm. Was the time that the patient wanted to use some of the agent, and we knew very well that let's go ahead with the previous experience of Urgo Clean AG, which has an autolytic debridement and removal of the biofilm. So we thought, okay, let's go ahead with this. It gave a decent results to us, and we thought, okay, after completing that, can we go with the continuum of care? And that's how we went with the usage of nano oligosaccharide, that is the Urgo Start. Now, if you look at this patient by day 7, the wound looked quite good. We started doing the dressing every second to third day because some patients come second day, some patient comes third day. By the end of 8 dressings with UrgoClean AG, we found out that the exudate had declined, the biofilm has disappeared, and you can certainly see the reddish head granulation tissue. Wound contraction also was quite evident. And once we saw that the visual biofilms disappeared, it was a time to shift. And this is the time that the continuum of care we took with another component, and that was the NOSF. We started using Ergo Start. You see the progression of how it had taken place. The total the duration of what you have seen the photo is 42 days, where the biofilm was there 0 from day 1 to an excellent granulation tissue by day 42, and exudate also had decreased drastically. How do we decide that exudate decrease is very evident? That look at the gauze piece. If you look at a gauze piece based on the Sussman's classification 1, 2, 3, and 4, when you know that it is less than 25% of it, the exudate is drastically decreasing. So we continued ErgoClean till we see that there's no visual biofilm presence in the wound, and then you can take a call to shift to ErgoStart. And this is how we did this case. This was a pre-planned case. From 3 months we were waiting where we can use an ideal case where everything should be visible. Detecting a biofilm in the lab requires a lot of expensive equipments, but there are certain signs which you can see visually, and that's how we saw the indication. And from day 0 to day 42, in between, you can see the photo of ErgoStart maintaining the good granulation tissue. So this patient is still with us till the total wound closure takes place. We will be following up this patient. We have another case. If you look, this patient was referred to us. He was known case of diabetic for 15 years duration, already amputated outside. Each one of you can see it, that there is no progression of healing. You can see exposed metatarsal. You can see slough and biofilms visible with pale granulation tissue. What we decided as a surgeon is go ahead with revision of amputation, redebridement. But in spite of that, we noticed that there was a presence of biofilm. And this was another ideal case. We felt that why not try autolytic debridement and biofilm removal through ErgoClean AG and see if it's giving a good granulation. Can we shift to ErgoStart? And this was another case we were able to go in the series of follow-up in the study. Again, every 2 or 3 days, because our OPDs are on alternate days. After 3 dressings, you can see the biofilm actually has decreased visually with a good granulation tissue. How do we decide it? Healthy red granulation tissue, edge being slopy, and the surrounding margins which are there showing the classical signs of healing. This is how we went, and fibrosis taking place. Once we realized that there was an excellent red granulation tissue, no visible biofilm, we shifted to ErgoStart to see how it can maintain. Again, same process were followed to see, and by day 35, we realized that there was a good granulation tissue with nil exudate. The word nil exudate is when you cannot see extensively high. There'll always be minor exudate, but when it is not visually seen very high, is the time we call nil. And you can see that every 3rd to 4th day of dressings, when we started progressing, this is how it has reached today. From day 0 to day 30, you can see how excellent granulation tissue are there. And in this case, we use something called microadhesive, where we don't have to really place, compared to the previous one that was a contact layer, we use ErgoStart that can fix directly itself. And by day 35, an excellent granulation tissue are there. Still follow up with us, whether it's going to decrease down or we are going to put skin grafting is what I'm going to tell the next time. Now, as they always requested, can you come out with new cases? And she said, since it's a research institute which we are working, give us time. Coming soon is that looking beyond diabetic foot, can we try to decrease the biofilms in different 6 to 20% of the patients can get acute biofilms in different part of the body. And you can see one of the largest gluteal abscesses which we are treating here, having an excellent extensive biofilm. This is what the ErgoStart clinic are going. It's doing good. I'll give you a final outcome in our next series. Thank you, ladies and gentlemen, for allowing us to share small case series. Yeah.
Thank you. Next, I will be calling upon Dr. Sanjay. His topic will be artificial intelligence and diabetic foot. Recent advances in early detection and screening of diabetic foot.
Can I have a handheld or something? Collar or handle? Whichever works. Good. So how many of you have heard about AI? heard about AI, artificial intelligence? How many of you have heard about AI in wound care? I just want to do this informally here so that everyone is awake. So instead of standing here and doing it. So everybody knows about me. I don't have to talk about myself, and for all the doctors. How many of you have got these kind of images? I surely get this plenty. And how many of you get these kind of images in your phone from your patients? Almost everyone who are all here. That's what we, and how many of us struggle with these images? Like going back, searching, how was it? And if you want to do a presentation or something, how do we search this wound? How many of us struggle with this? We all struggle. It's like then this is normal. Today, whatever the privacy laws or whatever that has been there, but this kind of image sharing amongst the doctors, a patient to the doctors, has been pretty rampant. And what are the challenges that we face? As I said, one is scrolling up and down when we want to present. Other is figuring it out which patient, which day he had come, what had happened to him, and we possibly ask them to dress it at home, or they get dressed in some other clinic in a remote part and start sending images. There is absolutely no track of this. So this was telemedicine sometime probably in 1960s. We thought, or there were images where it was thought that, something would be there, some device would be there where the doctor will be seeing the patient like this. And this is somewhere in 1960s, 1970. And then this kind of a telemedicine kiosk came into picture, where it was from 1970s to probably this is around 1990s, where we had this. And this, what we can see in 2000. We had already had mobile apps somewhere in 2000 to 2010, where it could take an image and we could keep a track of the wounds of the patient. And the next that would come in, or it is already there, I see, is the glasses, where we can have the glasses on you. You can operate it, or you can real time train the people. If the nurse is doing a dressing there, she can just wear the glasses and you can see what has been happening. And going forward, what we see is a metaverse. We already know that the Facebook has changed its name to Meta. Facebook is no more Facebook today, it is Meta. And what we are seeing tomorrow is the metaverse, where you can see these holograms actually mimicking whatever we have been doing. If you're sitting at home, and then our holograms will be able to treat the patient or diagnose the patient. It is not far away. Probably may not be in our generation, but it is not far away. So AI kind of started somewhere in 1950s. The concept of artificial intelligence and to treat wound care, or its implementation in healthcare, is started in 1950s. And today it is a buzzword. There was some kind of a lull much of the time, and today in about 2000s, 2010, 20s, this has become a buzzword now. There are a couple of things: rule-based, learning-based. When we are talking about learning, sorry, I know it is a doctor's, but I thought it was important to kind of get the hang over this languages before we actually talk about AI in wound care, what we have been doing. So we have machine learning, artificial neural networks, natural language processing, and computer vision. Computer vision is something that what is going to be useful in the wound care, and we have natural language processing also that's going to be useful in the wound care process. And last but not the least, what is going to help us, as what is going to drive healthcare or drive wound care, is the deep learning. So deep learning is a technique for implementing machine learning. It is based on the neural networks that we have. So it is inspired by the neural networks that we have, a structure or a function of a brain, specifically interconnecting of many neurons, that we know that. So the wound feature extraction using all these AI technologies, which involves wound classification, a lot of rule-based and machine learning and deep learning algorithms, is what we use in the AI of the wound. So the AI enabled feature recognition, what it can do, it can identify a tissue. So if you take a picture today, probably most of the apps that you have today will give a size of the wound. Or it could recognize the color of the wound, and then where you can decide upon whether it is black, it is necrotic, whether it is yellow, it is fluffy, whether it is red, it is granulating. But what AI can actually do using all these methods is tissue identification. Wound measurements and area, we already know. Wound depth is something that we could do. There are a lot of 3D cameras. Now that Apple iPhone has come with a LiDAR camera, we can actually get the depth of the wound just using an iPhone camera today. I do not know about the Android if they have a LiDAR version in it, but it is possible today. The color and texture, the texture of the skin, the texture of the granulating tissue is also something that can be identified by the AI. The wound bed recognition, whether it is a tendon, bone, ligament, soft tissue, something it can recognize, and the wound edge recognition. If it's an undermining edge or if it is a sloping edge, is something that we can recognize. As I said, there are several wound care mobile applications, from My Wound Doctor, from tissue analytics to Woundwise, Wound Desk, Illuminate, Vora Wound Care. The list is, I've just listed a few of them which I got on the top 10. There could be 100 plus wound care applications today on the Play Store and on the App Store. The challenge of these is, in a manual wound assessment, the size assessment that we do, it has been found out from the various researchers there are 44% errors in area and volume and characterization of the wound. In all the other apps that we discussed earlier, there has been 36% errors in volume measuring the AI models. The area is fine, but the volume measurement, there are 36% errors. There are 84% errors in characterization of the wound using AI models today. So we can still say that it's a long way to go. It is not, AI has not arrived there yet, but this is the challenge and this is what we have the scope to solve it. No work or invention has utilized all modalities. Like, for example, images, shapes, text, characterization. What most of these do is just take a picture and do a computer vision. They haven't looked at the data that comes into it. They haven't looked at the text, the characterization, and predictive. All of them together has not been there till today in any of the applications that has been available in the market. There have been researches for 20 patients, 30 patients, maximum 100 patients, but it is not there in the market today. So what we did was took that as a challenge, started coming up with a Wound 360 module. It's an AI model being developed by acquisition of multimodal data, that is 2D, 3D images, color correction, pixel segmentation, clinical text notes. So all this, we should be able to characterize, determine the area, volume, identify and grade the wound, and suggest evidence-based management protocols and predict healability of the wounds. So this is the intention of what we are trying to come up with. And don't worry, not to worry, this is going to be free for all the physicians. So what we intend to do is just take a picture of it, put some text. It will ask some questions of like, what is the age of the patient? What are the other comorbidities it is there? What is the odor of the wound? Or what could be the texture? Some of the things where AI cannot recognize as of today is going to ask some questions, and then it's going to suggest what is the grade of the wound, what is the stage of the wound, and then also suggest what is the kind of treatment. I know that you all would not need what should be the treatment be, but probably physicians sitting in tier 1, tier 2 cities where they do not know anything more than TBAT for a diabetic foot ulcer, for them, I think this would be useful, or this is targeted at. So this is the mobile tele wound care. So you can see some of the portals, the chat that is being there. This is the conversational thing. You can actually directly download it right away. It's on App Store and Google Store, free of cost. It is right now a documentation app. The AI is not enabled yet in the app that is available because we are only at about 65% accuracy. Once we reach 85% accuracy, the AI part will come into picture. But right now, it's a wound documentation app which is already available. So these are the few screenshots of how the command center would look like. If you log in, you can compare the wound, you can look at the data that is coming in, how it is, graphs, everything. All this is already available on the command center, which you can use free of cost. So there's a banner there. You can scan this barcodes and then just download it. So that's about So each time I talked about the artificial intelligence, this was the slogan that I was saying, I was using. Artificial intelligence, big data, machine learning, everything is here to transform healthcare. And if we don't adopt it, we are going to perish. But I changed it for now and going further. I am saying that the future of healthcare is not about technology, but about how to make technology invisible so that it fits inside a seamless workflow that is empathetic to the patient, where providers can put the technology away and spend their time in providing better care. So technology should be like stethoscope. Technology shouldn't be something that I would want to learn it and spend more time into it. And with this intention, we would want to come up with the wound 360 and the foot 360 for AI diagnosis of the foot and the wound. Thank you very much.
Thank you. Thank you, Sanjay. As usual, very captivating. I would request Dr. Srinivas to please come up on the dais to give a memento to Dr. Sanjay. Yes, technology is a double-edged sword. We cannot always depend on technology, but there is a saying, if you are standing on the road facing a road roller, you are either a part of the road roller or the road. So you have to take your call, right? Thank you. Coming next is Dr. Anirudh, recent advances in neuropathy detection and wound healing. Dr. Anirudh.
Good afternoon, everybody. Can we just have a skit for 10 seconds, if you don't mind? A small skit? Right. Yes. This is like in everybody's usual clinic, the patient and the doctor. The doctor has assessed the patient, and now this is what the patient and the doctor is going to have a conversation. They're still in COVID times, I guess. Difficult to come out of that.
Doctor, I feel so much pain in my feet and burning sensation, which makes me feel numb.
I think it's early symptoms of neuropathy, and I think this is a prescription that you should be taking, and it should get you better.
How can we know whether the condition has been improved or not?
Right now, we can detect neuropathy, but there are no ways to quantify it. We're still at the stage of only detection.
This is where all of us face a problem where we just cannot give them a quantitative analysis or a prognostic reporting, which helps them understand how their neuropathy is improving or deteriorating and going to complications, right? Right. So I'd like to introduce you to two new novel devices which we can start the presentation with. Thank you. They are my colleagues from Yostra, okay, and they are the pioneers in the development of these devices. Vinayak, I think they want some help. The penultimate goal of this particular conference is to prevent this. I'm sure all of you agree. Everybody wants to prevent amputation, correct? Yes or no? Okay. Remember that more than 30% of our patients who have undergone below knee amputation usually tend to die within the first year of surgery. And this percentage increases to more than 50% when it comes to above knee amputation. This is there in the books. No matter what we do, it could be social reasons, it could be psychological reasons, it could also be medical reasons. You agree? Yes. Good afternoon. I'm Dr. Anirudh. I'm an assistant professor in the Department of General Surgery from Kempegowda Institute of Medical Sciences. And today I'm here to talk to you about two particular devices. One in the detection of neuropathy and second in wound healing. We'll start with neuropathy detection and prognosis. Everybody knows diabetes is not just a problem of reduced insulin, reaction to insulin, or resistance to insulin. There's much more to it, much more organs which are also involved. And here we're going to be giving importance only to the foot. Okay. This ulcer is nothing but the tip of an iceberg. Whenever a patient comes to you, it is just not the foot. The foot leads to multiple other conditions like acute kidney injury or retinopathy or nephropathy or something like that, or probably even a peripheral vascular disease, right? So this is just the tip of an iceberg for the patient, which the patient might not accept, difficult for them to understand, but this is where we come in and try to explain to them of the situation. If it is in one foot, definitely he can develop in the other foot. This is where we need to bring in to identify early neuropathy and prevention and treatment. Another slide about this, which we have been speaking from morning till now. Okay. And these are all the symptoms that the patient can have, but this is only symptoms which is not quantifiable as of today. And we're going to bring in a device which helps you quantify these symptoms. Right. We have another speaker after mine who's going to be talking most about the neuropathy, the nerve injuries. Okay, and I don't want to stress much about it. It's basically demyelination of the sheath of nerves due to diabetes. Here, the main challenges are we need multiple devices which handle individual parameters. It is not digitized like the way we are speaking about AI as of today, right? It is not portable because I'm sure you saw the device which is kept outside. These are all huge blocks which you cannot carry it around or probably keep it in your clinic, which is quite small, right? You need to create a separate space for its placement. The accuracy also is not that good, okay? And last but not the least, it's difficult to validate. You come today, this is the report. You come in the next 6 months, how do I compare? We do not have a proper comparison method or parameter, right? We have a device, and that's this the device, which is handy, small, okay, and it has multiple parameters which can be evaluated, right? It's digital, it's wireless. Probably soon we're going to have a belt where you can fix it to your pant, and you can take it around, or probably even get your sister to assess the patient, come back with the report, and then you're already ready to see the patient. What all can we check? We can check for temperature. We can check for fine touch, hot and cold perception, and also for biases. What do we get after doing all this? We have a quantified reporting system, which I'm sure all of you have in your hand right now. That's just a specimen of the report. We get precise measurements. There is absolutely no observer bias, which is a very good thing today. And last but not the least, these reports can be interpreted and compared once you put the patient on treatment for the next 3 months, 6 months, 1 year, 2 years. And it's also useful for us to have published our cases. These are multiple publications, one I'm sure which Pawan also has done, and I think Sanjay also has. Sir has, yes, very nice. So this is not something new, but I'm sure Sir has had very good experience with this. That's Sir's publication, yes. These are just some of our clients. Okay, and we are pan-India as of today. Look at the numbers, 90%, 97%. Okay, this is the kind of quality that we are actually giving our patients. And the best part is your patients, you can show them in a comparative manner as to their improvement based on your treatment. What's the next best thing that we can have? We will provide you an off-site support, which is online 24 hours, 24/7, where we will start getting the load of the reports. We will send those reports to you, which you can take a printout. And at any point of time, you want any help or query, and we are here to solve the problems. We also provide training, free of cost, of course, for not only the doctor, for also other healthcare professionals, which brings down the burden of time consumed per patient by the physician. Okay, that's about NeuroTouch. The next thing that we come up to this is not just the problem of the surgeon. If you look at it, a lot of other departments are involved. You have nephrologists, you have ophthalmologists, you have physicians, you have podiatricians, you have specialists in footwear manufacturers, all of them involved in this particular condition. And this takes a lot of time and energy. I'm sure most of the surgeons, after 4 or 5 years of their early practice, they don't want to come in the middle of the night and operate such cases, right? They say, chalo yaar, junior kar do. And this is where we are losing much more cases to complications. So we want to see that we come in at a point where a debridement is done, the primary septic foci is reduced, it is coming to a position where we can heal it fast, and this point of debridement to healing is pretty long in a diabetic, unlike a non-diabetic patient. Agreed? Right. Where are we stuck? We are stuck at number 1, limited treatment options. Most of the diabetic wound ulcers are complicated ulcers. And last but not the least, in India, it's the cost. Even a guy who's a multi-billionaire will ask, mileage kitna deta hai? Yes. So money is a very important factor when it comes to treatment in India. What are the benefits with this warm oxygen therapy? We provide a particular device which increases the surface temperature of the ulcer to a point where its capillary flow increases, thereby increasing the oxygen saturation, number 1. Number 2, increased blood flow, thereby increasing the antibiotic supply to the wound. And third, this heat also will be rich in oxygen, which helps in killing the bacteria. All right. There's another 2-pronged benefit with oxygen, and that is it stimulates vascular endothelial growth factor and also new vascularization. With a lot of research, we came to know that when you blow hot air from your mouth, the split of a second that it exits from your lips, the temperature drops drastically. So our technology is stuck where trying to provide this heat of this air or oxygen as it comes in contact to the skin, which is very difficult to control. Right? So this is a device. The device sits either on the floor or on a table, connected to an oxygen concentrator. It heats up the air, which is maintained right till it contacts the skin or the ulcer in a controlled environment, like a bag. What are the benefits? Number 1, most of your diabetic patients have to come every day or go to a hospital every day for dressing, which comes at a cost of transportation and cost of dressing. Now, both can be reduced because we give on-site or at-home delivery of this particular dressing. Okay. So thereby we reduce healthcare cost. The physician's time is not wasted. The transportation is not wasted. Okay. And it can be done at the luxury of watching a movie. We had a patient who probably watched 18 movies in the 18 sittings that he had. So what at the end we need to know whether what we did was right or wrong, whether it was efficient or not. And these are some of the results which shows the efficiency of our device. You can see all this is within a span of week 1, week 6, week 1, week 4, and week 6. Okay. Similarly, this ulcer also. They say ulcers over the heel are big fighters. You know, we have to fight literally to see that it heals. And we found that this particular ulcer healed really quick. These are multiple studies that we have done. Okay. And there are some which are still ongoing also. And we have seen that the rate of closure of wounds is the fastest in comparison to any other modality of wound healing in the world today. And I can show you the journal which can prove that. Where do we come? Where does this device come into play? At what point do we start treating the patient with this warm oxygen therapy? You cannot take a patient who has an infected wound or a non-healing wound. It's of no use. It will not work. You cannot take somebody who's almost come to a closure. It will not work. It will probably reduce the time taken for a large wound to come to a healing wound. Okay. And this is where, rather than just doing dressings, this particular treatment only for 6 weeks max, okay, helps reduce the ulcer really quick. Patient compliance, patient's cost, and finally, efficacy. Like I showed you in the previous slides, it's quite efficient. It's very convenient because the patient is sitting watching a movie. It's just a 90-minute treatment time. And finally, the cost. It's pretty cheap compared to many other treatment modalities. This is the study where we have shown that the rate of closure of the ulcer is the fastest compared to any other treatment modality. Okay, we had a small studies group because number one, our inclusion criteria was very strict. We didn't want to take patients who had renal failure, who had peripheral arterial disease. We were only interested in patients who just had a diabetic foot ulcer. But this opened up a huge box of Pandora. And then we said, we are only comparing with ulcer which are graded by some American, by some Caucasian. We have an Indian guy who's actually had a diabetic foot ulcer classification. We need to start comparing those. We need to bring in our country forward, right? So that's another study we can do. Another study probably is for ulcers which have gone deep, right up to the bone. Okay. And if you look at this, this is the kind of treatment that we gave our patients. Alternate days, just for 90 minutes. Okay. And only for 6 weeks. We found that many ulcers, even after 6 weeks, had an increased rate of closure. These are some of the images where the ulcers have healed. Okay, this is post grade disarticulation. Another heel ulcer which has healed. These are fighters, I tell you. Okay, this is another ulcer which is in the mid foot. For this patient, we need to do something called offloading. Okay. Another ulcer on the medial malleolus. Okay. This was an infected ulcer where the tendons were exposed, and you can see the tendons getting covered really quick. Another ulcer post disarticulation. Yeah. I want to show you one particular ulcer. Yes. These ulcers, even though small, just don't heal because there's a very high chance of developing biofilms within 24 to 48 hours. So by the time he comes for the next set of dressing, it's already having biofilm. So it's very difficult to get this. What we found was within the first 2 weeks, the formation of biofilm reduced, and that helped good reach of warmth and oxygen to the ulcer. This was a patient who suffered from hemiplegia, okay, for 10 years. And as usual, diabetic foot, he had a fall, developed an injury. It was a callous ulcer, just had no signs of healing, a completely dry and shriveled ulcer. And somehow we didn't want to do much. We just started giving this kind of warm oxygen therapy. And we saw that it softened, it became moist, and it started showing signs of healing. This is one particular case. Okay, it's a recent case, okay, where we had wet gangrene. Okay. And post TMT amputation, transmetatarsal amputation, you can see the change, you can see the improvement, and you can see the cover. All this, trust me, in 6 to 8 weeks. Thank you. Any questions? You're talking about the study or in usual? Yes, sir. Normal dressing, what we usually do, just saline and clean with betadine surrounding and gauze. But that stays for 48 hours. Yes, sir. Of course. Yes. That's just 18 sets of those plastic bags. And we can even custom make these plastic bags, like Dr. Amit Jain was telling about a particular ulcer in the gluteal region. I'm sure you'll have a doubt whether it will not be able to treat, right? Because we cannot really achieve that kind of a closure. But we custom make the bags according to the patient's requirement. That's okay. No, sir. No pressure at all. No pressure. Because right now there's a company which has come up with hyperbaric oxygen. I don't know. Does anybody have their experience? Oh, that's nice. and you find good results?
Comparatively, I haven't compared between the two, but topical oxygen really gives good results.
Topical warm oxygen.
Topical oxygen gives good results.
Okay.
I haven't compared between the two. But
Irrespective of pressure or the temperature. So that's 50% one. Yes, sir. So would you please speak in the mic? Yes, sir.
Anirudh, Dr. Maya, Anirudh. Dr. Maya.
Sir.
With your permission, actually, I just wanted to add one point related to
Please.
neurotouch.
So positive or negative?
Negative, sorry, positive point,
Okay.
not the negative. Actually, the neurotouch, if you look at presently in the clinical practice, we have a monofilament. Monofilament, we assume that it is a 10 gram of pressure we are applying. But when we did the research, we have screened more than 1,000 populations with the diabetic neuropathic people, both with the monofilament as well as with the neurotouch. One of the important, the strength of the neurotouch is you can it is a semi-quantitative. Like a vibration perception threshold, we can able to measure the pressure also. How much pressure we are applying and when we are detecting the neuropathic changes. When we did the study on the normal population, in Indian, our cultural or the social aspect is different from the Western population. Even with the 15 grams of pressure, normal healthy individuals have they don't appreciate any change. So 10 gram of monofilament, whether it is sensitive enough to detect the neuropathy, that we need to think about in our clinical practice because of the lifestyle of our population. The second important point is they also use the barefoot. That most of the time they have a thick skin, the monofilament may not able to detect, but when you do the vibration perception threshold, they have an either moderate or the severe neuropathy.
That's really nice.
Yeah.
That's
So
really
we
nice.
have a database of normal as well as the mild, moderate, and the severe neuropathy, comparing with the monofilament of our Siemens as well as with the neurotouch. We wanted to publish that.
We are very soon going international, sir. So
Yes,
I think
yes.
we should keep this in mind before we go and tell them
Okay.
this.
Okay. Thank you.
That's nice.
That's what Dr. Anirudh.
Yes, sir.
I just wanted to know what is the total cost of the treatment on average?
Total cost of which treatment, sir? The
last one.
Okay, the warm oxygen therapy.
Yeah.
Right. So see, as of now, we are trying to tailor make it to the doctor according to his requirement and according to the patient's requirement. We are somewhere in the range of 800 to 1,000 rupees per bag, and probably the treatment will come free. Okay, this is where we are the costing right now, but it depends on what kind of patient, and then it depends on what the surgeon also wants.
Will it be insurance cover?
So insurance cover.
Yeah.
So insurance cover for wound care. The
Sir,
patient-
insurance does not even cover VAC as of now.
No.
Let's forget Velox.
So
Even VAC is not covered as of now.
I
So I'll
think
come
it's a
back to
high
this.
time they come, they change with the times.
No, sir.
There was a time when even daycare was not recognized.
Yes.
They were not giving it.
Yes.
24 hours ambulation.
Yes.
And surgery was required.
Okay, because of paucity of time, Anirudh, let me please make justice to Srinivas sir and Prashant sir.
Yes,
They are looking at me as though I have called them in the morning and I have made them sit throughout the day. Please, Maya sir, if you can just give a small memento to Anirudh. Sorry, if anyone has any other questions, they can take it in person with Dr. Anirudh.
Actually,
So as I call, they are our tail enders now. So one will be Hardik Pandya and I don't know about the other. So we will be calling Dr. Srinivas, who will be talking on management of diabetic peripheral neuropathy. What's new and what can be done? Yes, sir.
At the outset, let me thank Pawan and congratulate Pawan and all this team at KIER and the IPA Karnataka Chapter for doing a wonderful show here. There are very few new things because right from the morning, all of us have been talking about neuropathy. So namaste and greetings from the Apollo Health City at Hyderabad. My talk will, the assigned talk to me is the management of peripheral diabetic neuropathy, what's new and what can be done. But the important thing that one needs to realize, or what I need to push across to you as one of the take homes, is there is a journey from a painful to the painless. Neuropathy, probably more than the painful aspect, the painless aspect is what needs our compassion, what needs our passion to prevent these amputations. It's a diagnosis of exclusion. All of us know the ADA has termed diabetic neuropathy as the presence of symptoms and signs of peripheral nerve dysfunction in people with diabetes after exclusion of other causes. We'll come to the other causes in a couple of slides from now. So this is what I was trying to say. One extreme, you have extremely painful patients, which include severe hyperesthesias and allodynias, where even the touch of their touch of their clothes or touch of the bed sheet itself can trigger painful activity. On the other end, loss of protective sensation or painless neuropathy. So painless neuropathy leads to a lot of pressure changes in the plantar foot, which we've been talking about, formation of the ulcer, and then finally an amputation. How do we break this chain is what I need to push across. It's typically a symmetrical neuropathy of both the glove and stocking, both extremities, the glove and the stocking pattern. It can still be asymmetrical neuropathies or focal mononeuropathies. Multiple pathogenic factors lay, and all the medications or drugs that we use will target one of these pathological mechanisms involved in to reduce the pain. So it's basically an axonal degeneration that happens in the peripheral nerves. Men are supposed to be more predisposed than women, and this is the typical the typical symptoms that we come across: numbness, stabbing pain, burning pain, very sensitive to touch. The extreme ones, like I just mentioned, allodynia, coordination difficulties or balance issues, muscle weakness, again, which leads to balance issues, inability to wear their socks and shoes properly, slipping off of their shoes, and autonomic neuropathy has bowel and bladder issues as well. So we just talked about these symptoms and signs of neuropathy. Again, numbers behind neuropathy, I think in the US itself, reported literature says about 30% patients of diabetes have some amount of neuropathy. 60 to 70% of diabetics have peripheral neuropathy. Now, what the other causes, why we said it's exclusion, it's a diagnosis of exclusion. You need to rule out history of alcoholism, history of vitamin deficiencies, particularly B12 and D deficiencies, vasculitis and lupus related issues, hypothyroidism, and chemotherapy or cancer itself can cause peripheral neuropathy. Once we have ruled out these causes, then label it as diabetic peripheral neuropathy. The other thing I want you to realize, all of you to realize here, is that in many an instance, in many a patient, we have combination. In addition to diabetic sensory neuropathy, patients still may have a vitamin B12 deficiency or a vitamin D deficiency. And when you target those risk factors, which if we find them, probably the outcome of treating the pain is much better when you try to look for them and treat them targetedly, these risk factors. So 2 questions you need to exclude all the other causes, treat them along with the diabetic neuropathy, and then you can see the by date. So anyway, we've been talking about all these devices. The Ipswich touch test, which says that the clinician's finger itself is enough to diagnose the neuropathy, is the latest. You don't need costly equipment. But anyway, to pick it up much earlier, we just had a dynamic speaker, Anirudh, who told us what can detect neuropathy much earlier than what we normally can do clinically. Anyway, so these are screening tools that we use. Nerve conduction will show us delayed velocities in the nerve conduction, EMGs, and then rarely those nerve biopsies are needed. How do you manage peripheral diabetic neuropathy? I think the 4 keystones we need to look at is slow down the progression of the disease. The only agent, the only known thing to mankind to slow down the progression of the disease is a good glycemic control, and a good glycemic control. Only if your target A1Cs and the metabolic control is adequate, your neuropathy cannot, at least you cannot be slowed down. Nobody can reverse neuropathy, but at least slowing down of the disease. Now, second will be relieving the painful aspect of neuropathy. Third will be to manage the complications of neuropathy and restoring the function of the nerves. 4 will be to something to regenerate or nerve repair. So largely, I will talk about drugs, device, and decompression of the nerve. Like I said, slowing down the progression, an adequate metabolic control is what needs, and that's the only thing which is known to slow down the progression of neuropathy, in addition to the other metabolic control that you can see up there. So, coming down to the relieving the pain, you have drugs which include the first line agents, which include the gabapentin, the pregabs on one side, the TCAs, the tricyclic antidepressants, duloxetine on one side, you have tramadol and other opiates on one side, and then you have topical medications. Then you go down to the second line agent. So how do you treat them? You ideally start with one line agent and increase it to the maximal dose. And once you increase it to the maximal dose, still you don't find response, you switch over to another first line agent. That also, in spite of giving adequate doses, you don't achieve your desired clinical effects in reducing the pain, then probably use a combination of two first line agents. And till date literature says pregabalin, which is the active molecule from gabapentin, and duloxetine are the only two drugs which actually have clinical benefit in reducing the pain. Then in addition, you can also resort to lidocaine patches, and nowadays we are also having a lot of products which are based on gabapentin local application along with lidocaine. The opioids, generally we try to avoid opiates because this is a long-term chronic issue that we need to manage. If the pain doesn't go away, opiate dependence should not happen. So I will not, though it's mentioned in the slide, I will want you to use pregabalin and duloxetine as the first agents. Switch between the two if you don't get the adequate clinical response, and then probably if you don't, the third measure you would take is a combination of these two in addition to the local therapies. So level A evidence only pregabalin has, whereas duloxetine, amitriptyline, gabapentin have level B evidences. You can see that the literature strongly promotes only two molecules, which is the pregab and the duloxetine. Lignocaine largely, but again there is no definite literature saying that it is very helpful. Capsaicin patches do help, but not to great extent. Topical applications to give relief of that painful symptom or the burn at the skin. And the other thing is, one aspect is autonomic neuropathy leads to severe dryness and fissuring and callus formation. So you probably need to use moisturizing creams based out of allantoin, based out of urea, based out of intense moisturizing things like shea butter. So this may help in preventing that initial crack in the skin. Coming to devices, I think I don't use any of these devices, but electrical nerve stimulation, use of light therapy, which include LEDs, which include IR-based systems, which include laser, which I think Dr. Maya and Dr. Pawan have been using, which have been talking to them this morning. Finally, nerve growth. There's a lot of role of physical therapy and exercise, which again needs to be explored and researched onto, because not much of paper work, but it definitely says the limited papers that are there definitely say that physical therapy has a role in reducing the pain in diabetic peripheral sensory neuropathy. Now, what as a surgeon can we do? Decompress the nerves. But if you decompress all diabetic nerves, do you get rid of the neuropathy? The answer is no. Probably you can decompress when there is a definitive compression proven, and the compression proven can be either through a positive Tinel sign expressing the hyperalgesia by tapping the tibial nerve on its anatomical course, or the nerve conduction study, which shows reduced velocities pre and post the normal anatomical narrowing of the nerves. Again, this is limited experience across the world. I think Professor Vivian Murthy from Chennai advocates nerve compression. So that is how the nerve decompression is done, usually done under tourniquet guidance in local anesthesia, use diathermy, lay open the epineurium, primary closure of the wound, posterior slab or POP to support the foot, and non-weight bearing for a week is what people follow post decompression. And what Professor Murthy's paper, Professor Narayan Murthy's paper said is the 2-point discrimination before and after decompression of the nerves show a significant difference. Couple of patients and couple of papers he has presented everywhere across Indian meetings. We see that in patients who have wounds, the feet that had the decompression never had a recurrent ulcer again versus the feet which in the same patient. the feet which were decompressed because of the ulcer heals. The recurrent ulcer never happens to that feet. That's what we need to see. Diabetic foot clinic is definitely should lay all our eggs in prevention rather than in treatment. Usually Professor Baal's statement is no complaint, no examination. As the patient does not have pain, we generally as primary physicians or primary caretakers of diabetes, we hardly examine the feet. This is again another thing to keep the clinic clean. We keep this board in most clinics. I think this all diabetic clinics should remove this board first. And all that it needs to examine these feet to identify the risk factors is just a pair of good sensible hands and eyes and the knowledge. If you do not treat diabetic neuropathy the way it has to be treated, the journey continues from a painful to a painless foot, from the area of the pre-ulcer or the high foot pressure points, like you could see the pre-ulcer or the callus that you could see on the left, to an ulcer which gets complicated to infection, and finally to a recurrent ulcer. And it is on us to decide. And it is on us to decide where we break this chain, because if you leave that neuropathy untreated, definitely the pain after a couple of months, it's self-limiting, the pain will come down by itself. From there, it progresses to a painless part, which we need to be focusing our attention to the areas of the high pressure or the pre-ulcer, the ulcer, and the post-ulcer, which is the recurrence of the ulcer. So this is the pathway through which a painless foot would go. Areas of high pressure, which we are trying to learn from the pressure scans and what the scans mean to devise the offloading footwear or to devise the best offloading measure to the patient so that the ulcer is prevented. If the patient has an ulcer, still the same pedo program will help us, or the pressure map will help us to reduce the pressure and get the ulcer to heal and prevent the recurrence of the ulcer. If that is not done, what happens is patient continues to walk on the ulcer, fails to heal, it becomes chronic ulcer, gets infected someday, part of the foot is lost, partial foot amputation or a toe amputation, again remnant foot, high pressure. So we need to break this cycle as early as possible, preferably in the first cycle. The minute you see the pre-ulcer, that is when the time to act. So I cannot bring Jennifer Lopez's legs like Professor Tushar brought, but anyway, I've got as beautiful somebody. So the 5 beautiful things you need to think about the diabetic foot are regular care of the calluses, protecting them with very much suited and prescription footwear based on CAD/CAM or based on whatever newer technologies we have today. Reduce the pressure. Rarely when the pressure reduction in terms of the cast or in contact cast or in terms of the shoe does not heal the wound, then you need to resort what Madhu was talking about, the surgical offloading procedures, including the metatarsal head excisions, your gastric soleus complex releases, the sliding osteotomies, etc. And then most important, even if the ulcer heals, they need to be protected on special footwear lifelong. They need to be knowing that the sensation is gone. They need to be knowing that the structure of foot has already changed. So it's a continuous thing that the patient has to be educated to taking care of his or her feet throughout their lifetime. And then the 6 controls, as all of us know, will be the pressure control of the offloading. We had a wonderful talk on the vascular assessment and the revascularization that we can do. Microbiological control or take care of the infection, wound control about all the wound dressings, including the oxygen dressings, which we just heard now, educating the patient, and primarily, most importantly, the metabolic control of the patient, because that is the only thing which can prevent the progression of neuropathy till date, proven till date. A simple neuropathic callus or a pre-ulcer with a hematoma, all that it needs is shave of the callus by your paramedic, give them right shoes. So the effect of neuropathy is what I'm trying to show in the next couple of common presentations. This is what I'm trying to see. Calluses, just shave the calluses and give them. Deep fissures, you can see cracking because of autonomic neuropathy. Fungal intertrigo, which somebody just talked about in the previous lecture. You can see something from outside is so, it's like the tip of the iceberg. When you actually do a skygram, you can see that the 5th metatarsal head is entirely eroded and eaten away. The other thing is, again, neuropathy, loss of protective sensation, prick, pin prick. You can see the pin X-ray. You can see the pin coming out intraoperatively. We tried to, the amount of damage it causes. So that was the pin which caused the trauma. And the skin is basically very dry and probably has a smell or a texture which attracts both ants as well as rodents. And again, so we need to be careful that the moisturizer should be a neutral one, not the vegetable oils, because vegetable oils like coconut oil can sometimes do this harm. This one is a patient who had a rat bite injury, had a heel ulcer, in treatment at home in the middle of the night. Next day when the patient came for a review, what happened to your third toe? The third toe was there in the night. A rodent came and ate away the. So hypertrophic nails, again, the patient did not have sensation. They tried to do home surgery, causing iatrogenic ulcer. So again, unless we treat the pressure in the neuropathic foot or in the painless foot, we cannot achieve the healing. This is to be condemned because it tends to slip off and it tends to accentuate the toe deformities. The strap can cause trouble like this. And then the strap can be wrongly worn because the patient has neuropathy. It doesn't know where the strap goes, and this is what happens. Rings are good, but not to the extent of causing an incarceration and a cellulitis like that. Finally, with great difficulty, removed. Sometimes we may lose the toe. Anyway, it definitely takes a team approach, like all of us heard, a podiatry, a diabetology, a pharmacist, a general practitioner, the physician, the orthotist, the skin, the nephrologist, vascular surgeon, the orthopedic surgeon. All of us are needed to as part of the interdisciplinary team or the multidisciplinary team or the MDT, as the world is focusing on. So give a good wound care, 4 weeks, it should heal. If it doesn't, then you think of the advanced therapies that you can see on the right. So again, I'll end my talk with where Amit started. It's again a 3-minute examination that the ADA has recommended. Ask, look and feel and educate the patient. 1 minute to ask the patients pertinent questions. 2nd minute to look and feel. 3rd minute to educate the patient. What are we trying to screen through the 3 minutes? Any previous, what are we trying to screen? Any deformities? Any hot, red, swollen foot, which could be an acute Charcot foot unless proved otherwise. A chronic Charcot rocker bottom foot where the arch is collapsed completely. Significant high arch foot with a lot of deformity and callus. And a patient who had a previous surgery, previous amputation on the other head, lesser toes have gone, healed, high pressure under the toe, active ulcer with infection on the contralateral right foot. So these things we need to screen. If any of these risk factors are there, they fall into the high risk. So this is what we need to do. Stop. I think even our vascular surgeon did tell us, when you see the red, you have to stop. MDT has to act. Your vascularity needs to be checked. Your infection needs to be debrided adequately. Microbiology or infection control, wound control, all the 6 controls put together. If you don't have the red and it's just the orange or the yellow or the green, categorize them into low, moderate risk, and then probably the plan needs to be constituted. So again, I leave you with the beautiful lady, the 5 basic things that we need to take care of this diabetic foot to prevent amputations, to prevent neuropathy from progress is or rather the effects of neuropathy from progress are these 5 P's. I'll thank Pawan for the opportunity given and hand over. So this diabetic neuropathy is definitely, I think this is the last slide, definitely despite a lot of advances in diabetic neuropathy, we are far from success. Many areas of research needs to go into painful diabetic neuropathy. So I thank you.
Thank you, sir. Can I request Dr. Tushar to just present a small memento to Dr. Srinivas? Thank you, sir. As expected, the tail enders, always hitting it for a 6. Thank you. And now for the last talk of the day, I am very privileged to introduce one of my own. He's an orthopedic surgeon, Dr. Prashant Nagraj. He'll be talking on, again, one of the most neglected complications in diabetic foot, that is Charcot's. We have only quite a few people across India who actually do surgical management of Charcot's. So over to you, Dr. Prashant.
Good evening, everyone. Hopefully everybody is awake. And at the outset, I would like to extend my thanks to the organizing committee for giving me an opportunity to talk about something which I really relish upon. Trust me, waiting until the last session of today will definitely give you some of the salient features which will be a good take-home message. This will be a complete run-through from what has been happening since morning. And what I will be dealing with is in a very simple terms. If you find a patient coming to your clinic with a diabetic Charcot, how you are going to get through with that. It was rather interesting when Pawan actually spoke to me and he said to talk about the blow hot and blow cold. Any one of you, do you understand what the phrase blow hot and blow cold means? As a matter of fact, it was even confusing for me. I actually went through the dictionary when he actually gave it to me. Yeah, the dictionary terms of blow hot and blow cold basically means to be indecisive, changing the decisions every now and then, not very be clear about what we have to do. And that is diabetic neuroarthropathy. In spite of all these discussions since morning, all of us will finally find lots of daunting tasks. We are indecisive about how to go ahead. Let's try to see and try to do some justice for this. Ladies and gentlemen, let's start with this. Yeah, I've been trained in India, I tried abroad, and fortunately I had a great opportunity to work with the best foot and ankle surgeons. I'm going to deal with the diabetic Charcot as a multidisciplinary team approach, cooperating with the regular team from the orthopedic perspective. So this is going to be a paradigm shift as well as contributory to prevent the amputations in diabetes mellitus Charcot. This is what I was talking about. Of course, most of the time we are really worried about what to do and what not to do. And that's called as a blow hot and blow cold. Let's end this debate for once. Let's take each and every questions into perspective. Now, what's very interesting is I went to about 10 general physicians in and around the place in North Bangalore and discussed with them what is the questions they usually face when they see a diabetic Charcot patient. Now, because most of the treatment is a shared care decisions, we should be able to answer the patient's relatives how to deal with such patients. So let's see all these 10 questions, which has been validated by the general physicians across the North Bangalore. These are the questions, and I'm going to take each questions per head, and we are going to answer them. So by the time you go home today, you have a clarity about how to deal with these patients, okay? Now, the first question is, if a patient presents to you with a red hot swollen lower limb, now the first question that strikes to your mind is it diabetic Charcot? Is it cellulitis? Is it osteomyelitis? Is it DVT? Is it SFLS? Is it an acute attack of gout? So you've got a lot of differential diagnoses coming to your mind. But trust me, by a common consensus, if you see an afebrile patient with a normal vital signs, presenting with a unilateral swelling, which is hot, red, and swollen, by and large, this is a diabetic Charcot, but it can be bilateral in about 12% of patients, according to the Fozzi et al. But what's rather interesting is there is a definitive dissociation from the systemic presentation and the patient's local inflammatory response. So once you see this patient, what is the commonest thing we need to do is do the temperature check, we obviously do, and try to lift the limb for about few minutes and see whether the redness settles down. Majority of the time, the redness settles down. Now you have got a suspicion of this patient having a diabetic Charcot. You run them through some blood investigations. The BMI has got a very important contributor factor because it is predictive. The higher the BMI, higher the chance of complications. You should have a complete details about the diabetes mellitus treatment. The commonest questions which the GPs ask me is, what is the cutoff of the HbA1c for a patient to develop diabetic Charcot? Now, there was a wonderful paper published in Australia. They say the commonest cutoff for the HbA1c is 9% and above. So patient not managing the diabetes well, and if the HbA1c has been consistently about 9 and above, they are at a higher risk of developing diabetic Charcot. And normally it takes about 10 years in a patient with the NIDDM, non-insulin-dependent diabetic patients, to develop a diabetic Charcot. And for the diabetic Charcot with ulceration, it takes about 14 years. This is an average, the publication so far. The blood urea serum creatinine may be normal, may not be normal, depending upon the nephropathy. But what's rather interesting is the inflammatory markers in terms of WBC, ESR, and CRP will be relatively normal and stable in these patients. There was a recent article published by one of the interesting it's from the Indian literature, which is published in the International Journal of Endocrine Medicine. They said procalcitonin has got a very important prognostic indicator, but it's not been very conclusively accepted. It is just a few papers, anecdotal papers now and then. Now, since I have done the clinical examination, I have done the blood investigations, I doubt this patient is Charcot. Shall I request the x-rays for the patient? Yes, X-rays are important. That is a basic tool. But what we do in the X-rays is, from the orthopedic surgical perspective, we know exactly where is the Charcot developing from. At the same time, we measure these angles called as the Meares angle as the calcaneal pitch, because that helps us to know whether the Charcot is progressing or it is static. More interesting for most of us, when we look at the X-rays, a horrible looking X-rays with the demineralization, distractions, with the changes in the bone density, dislocations, horrible looking bones, wobbly bones, is diabetic Charcot, more or less in majority of the cases. But is the X-ray right in diagnosing the diabetic Charcot in the early stages? Let's have a look at this patient. A 50-year-old patient presents to the clinic with an acute attack of a heart, soul, and limb. They got the X-rays done, but in the X-rays were absolutely normal. But at the same time, getting an MRI done, it was so sensitive enough, it picked up. This patient is having a bone marrow changes in the stir sequences, mainly in the T2-weighted images. So an MRI scan can actually detect the Charcot before an X-ray can show, because for an X-ray to show the features of Charcot, at least 30% of the bones need to be destroyed. And the same thing holds true. So for the earliest management of the diabetic Charcot, MRI is the key. And the place where I worked in Bristol, we used to consider MRI scan for all the patients with suspected Charcot. It also helps to understand the clinical pathological dilemma that we usually face. We all know the basic anatomy in the foot. What basically happens is the metatarsals, they try to dislocate superiorly and laterally. And if you look at the middle arch, the talus tries to come down. It is more into the plantar side, and the cuneiforms, they are the culprit. They come out and they're completely dislocated medially, and they are the part which starts causing ulceration majority of the cases. So this can be clearly seen in the MRI scans. And of course, if you're suspecting an infection in diabetes mellitus, MRI scan has got a very high negative predictive value. What I mean by negative predictive value is, if we consider MRI scan is negative in this case, there's a very high chance it's unlikely to be an osteomyelitis. So you don't have to run the patient through next type of surgery or antibiotics. So I rest my point over there. So now we all know X-rays are good, but MRI is more sensitive for that diagnosis. So when we saw the patient clinically, we got the X-rays, we got the MRI scan. Now, since it is heart swollen, do we have to start the patient on antibiotics? Please, let us not start this patient on empirical antibiotics, because we have faced the problem of superbugs. But if we have to put the patient on antibiotics, there's only few indications where there is an ulcerations with a bone visible, infected ulcers, ESR is rising, and the ulcer is greater than 2 centimeters square, a 3 millimeter dip. So these are the conditions where we may have to consider starting the patient on empirical antibiotics, which is covering the gram positive and gram negative more so in Indian population. Now, the next question is, okay, now I have started, I know the diagnosis, I confirm the diagnosis, do I have to refer the patient to the diabetic foot surgeons? This will be the most important take-home message for today. Let me hit the alarm button today, because acute Charcot, it may actually present as an acute diabetic foot attack. Professor Venu Kavarthapu from London King's College, one of the pioneers in the diabetic foot management from the orthopedic perspective, he has presented this paper along with Prashant Vyas, where they confirmed that the acute diabetic foot attack is as equivalent to a stroke, as equivalent to a myocardial infarction. The only problem with the stroke is, yes, you can actually, the time is very limited. You have to work within minutes and within seconds sometimes. But in diabetic, thankfully, we have got time to actually act to save the limb. So we can actually save the limb, we can save the patient. So that's what we can actually do for. So be extremely careful when you look at an acute inflamed joint, which can rapidly progress, leading to tissue necrosis, sometimes leading to catastrophe and limb-threatening problems. I don't know whether you guys can clearly see, there are two images. The image on the left side, this patient had, the moment you see that, you know that it is very infected, it is pussy, it is swollen, there is a lot of collection inside. And the X-ray shows there is already a destruction on the bone and he has already underwent a previous amputation. These are the patients who need to be admitted, kept the limb elevated, get an MDT done, get the patient to the theaters, do the debridement, wash out, and then do the vascular assessment and plan for a plastic reconstruction or an amputation. But if you look at the second case, where the skin is already black, don't rush for an amputation. admit the patient, limb elevated, MDT, get the vascular assessment, and then plan the next treatment, which will be a fashion of a proper amputation. So this is very important for us. Now, the next question is, now I have found the patient, I did every investigations. Now I have the patient with the Charcot. Do I have to cast the patient or brace the patient? I had a discussion with my colleague recently, because the gold standard for majority of the patients in Eikenholz part type 1 is total contact casting and non-weight bearing. Trust me, this is the gold standard. We all have to follow the same. But we need to be technically very clear about how we have to apply the cost. And more importantly, there is a lot of videos, even from the British Orthopedic Foot and Ankle Societies. There are videos on the YouTube, which clearly shows how to apply a total contact cost for the patients. It's more educative and instructive. Now, once we apply total contact costing, we need to see this patient every week. We need to reassess the patient. So this increases the number of patients, OPD attendance, and there will be a lot of compliance issues. So then we started looking at whether these can be managed only with the total contact brace, something which behaves like a total contact cast, which is a brace, which is a pneumatic brace. If you look at the demerits with the TCC, it requires several applications and patient compliance, and sometimes we may not be winning over here. So recently, there is a general acceptance the patient can be managed with a pneumatic brace, so that the patient, there is an improved compliance, and we don't require a technical person assessing the patient all the time. Now, I have put the cast, I put the brace. Now, the next question is, can I allow the patient to walk on it? The gold standard is don't allow the patient with a total contact casting to walk on it. But now, again, the publications have shown patients with a Charcot, even with the ulcers, can be allowed to put weight and they can walk on this. So now we are seeing a sequence of events. Patient has come to the clinic, we have diagnosed the conditions, we have investigated, confirmed it, put the patient on the cast, and this is the patient which needs to be referred to the diabetic surgeons as early as possible. Now, when the patient comes to the diabetic surgeon, when the orthopedic team comes into the picture, the question we face is, do I have to operate the patient immediately at the acute Charcot, or do I have to wait and watch? So that's what this is again about. Strike while the iron is hot, or haste makes waste. Trust me, this is what, when I discussed with my orthopedic consultants whom which I have worked with, Mr. Heppel, Mr. Vincent, and Mr. Bagler, when I discussed about when they would operate, the ideal way of prefer to delay the surgery until the acute edema and the redness settles down, because that becomes much more easy to control the situations. But of late, there is a general trend in try to offer the surgeries at the early stages. Now, if I had to wait, or if I had to go ahead with the surgery, now these are the patients which cannot wait. If I wait, the more it ulcerates and more unstable. If the patient is not going to improve, and we are going to end up having more and more complications. Now, these are the patients in whom, from the orthopedic perspective, we have to go and stabilize the bone, the joints, so that there will be less amount of tissue breakdown. Because once the tissue breaks down, the vascularity, the ulcerations, infections, osteomyelitis, chopping, amputation starts there. So we need to be careful over there. So this is the main reason why we need to act fast on such circumstances to operate on these patients at the earliest. Now, do you have to be aggressive all the time, or is sometimes less is more, or more being less? If you see this patient, he just has got a toe ulceration on the top. All of you may believe that this will actually improve with the wound healing. No, this is a clot deformity. The deformity needs to be corrected. We need to straighten it up. We need to fuse it, probably use a sediment or some sort of antibiotic mixed cement if there is a doubtful infections. Fire some wires inside, allow it to fuse. That prevents the toe ulcerations and infections. If you look at this case, it was just an exostosis that was causing the ulceration. So you remove the exostosis, the patient completely heals. Look at these two cases. This patient presented with the forefoot increased callosities and ulcerations. You may be surprised, why am I trying to do a surgery in the calf in such patients? The forefoot ulceration in this patient is because of the tight calf muscles. For us from the Orthopedic Foot and Ankle Society, somehow we are more keen on seeing whether the pathology starts from more proximal than go more distal. Yes, it was a tight calf muscle. So once we tried to get the gastrosoleus lengthening, obviously the loading was reduced and the ulcers automatically started healing by themselves. They are non-infected ulcers and they healed completely well. So these are the conditions where we can do less is more. But what if the mother nature goes on a vacation, and as you see in this foot, the medial cuneiform is already ulcerated, the skin is already threatened, it's already exposed. This is osteomyelitis, and these are the patients where we need to take it head on. We need to, from the orthopedic perspective, the medial arch has to be stabilized, the lateral arch has to be stabilized, the cora has to be noted. We have to do the deformity correction, looking at where exactly is the cora, and then go ahead and treat it straightforward. Otherwise, these patients will soon ulcerate more, lead to more and more complications. What about this case? More challenges to start with. As you see, the distal part of the fibula is exposed, sloughed, infected, pussy. So these are the patients where we have to debride, wash out, take off that part of the fibula, apply an external fixator, have the control of the infection, put the antibiotic bits inside. And once the situation settles down, we can start with the internal fixation and make the patient starts walking on it. Advantage of putting an external fixator is we can make the patient walk on it immediately. So the external fixation can tolerate osteomyelitis. There is no risk of any fractures. Even though the bone stocks are pure, we can actually go ahead and fix it, and pseudoarthrosis may not affect the outcome. So external fixations is definitely stay. But recently, renowned interest because of the improved methods of internal fixations, where we use the internal beaming for the medial and the lateral arches, we can still get away and prevent any such complications. And with the advent of the antibiotic mixed cement, we have more control of the infection segment. We can get away with causing least complications to the patients. So this is my plan. It's a definitive working algorithm where the plantigrade foot, I'm not going to operate this patient. Only the non-plantigrade foot. If it is infected ulcer, I would X-fix it. If it is not infected, I would like to infix it. If it is a failed infix, I would like to X-fix and then infix it. This is how the orthopedic surgeon would like to actually plan it. By all the reasons, what we are looking at is, yes, we are all working with a united concern that we have to avoid amputations. We are all here only to do that. And that is what we have been discussing since morning. I will prevent the amputations in diabetes mellitus. But there are few conditions where, irrespective of however heroic we are, sometimes we have to agree to Mother Nature because we had to end up offering amputations in such patients. They are when there is a life-threatening and limb-threatening infections which cannot be controlled, presence of deformity that cannot be reconstructed in whatever way manageable, or unable to restore the good circulation to the limb. So you can't actually try to experiment more. Let me show this example. This is a patient with a diabetes mellitus. Try to undergo a midfoot reconstruction there and to do the hindfoot stabilization. But this hindfoot stabilization got infected. If you see the osteolysis here, the hindfoot stabilization structure was taken off. The screws was actually loosened. They were also removed. Initially stabilized with a wire with antibiotic mixed cement with an external fixations, and then the wires were removed, external fixations was removed. Then we had something called as an cages. So we put a cage and then made the patient walk on it. And the whole treatment took about 2.5 hours for the patient, 2.5 years for the patient. So these are the cases where you need to be extremely careful. You can't make the patient to work on this for 2.5 years, losing his jobs, family is dependent on him, and he's going to lose the main prime point of his life. So be extremely cautious in such cases. Don't keep on waiting. But if we can save the limb with the patients from the patient, and the patient is happy to wait with the time, go ahead. Finally, it's worth it. The limb saved is a life saved. These are the patients who have the risk of amputations, Charcot's, longer durations, dyslipidemia, neuropathy, and peripheral vascular disease, and CABG patients have got a higher risk of below-knee amputations in diabetes. So this is more interesting. What's interesting about this thing is, yes, we are all looking at how we can prevent. So preventive podiatry is the key. Yes, we can actually prevent the amputation. That's what we are all aggressively looking at. And looking at the series of publications, I think this is the only time I saw NATO and non-NATO countries are not at war with each other. Many of the countries, maybe Netherlands, Finland, Italy, Lithuania, United Kingdom, Asia, India, Australia, everybody together in their publications confirmed the limb can be saved. This is the theme. The limb can be saved in diabetes mellitus only when there is a multidisciplinary team approach. Otherwise, there is a risk of actually losing the limb. And this should be the take-home message as a big fact today. And that is the publications there. So that's why NICE guidelines is also very imperative. We are very clear about how involving multiple team. We need to have diabetic nurse, podiatry, unitedly working together to save that limb, that crucial limb for the patient saved, is a crucial life saved for the patient as well as the family. And that's what we all have to be working towards now. So as a take-home message for the final thing, we are looking from the toe to flow, from the podiatrist to the vascular surgeon, involvement of all the multidisciplinary team. We should work to make sure patient doesn't lose their limbs. Diabetic Charcot is an acute medical condition, and the theme is the time is the tissue. Remember, acute diabetic foot attack is nothing less than an acute myocardial infarction or any stroke. This is very important. MRI is now turning out to be a gold standard. Early surgical management is very important, and multidisciplinary team approach is very quintessential to prevent the amputations in this management. Thank you so much for your kind hearing. Hope we will do justice in preventing amputations to all our patients. Thank you very much again.
Thank you, sir. Now I am biased towards him because my tribe. So let me give him some questions. Any questions, please? Charcots.
Please feel free to ask questions from the clinical examinations to the diagnosis to the management. Anything under Charcot.
Actually, the question which you had raised, that making a diagnosis still it is a diagnosis.
We try to actually clear the confusion. Clinically, as well as by the radiologically, we should be able to establish the diagnosis. We should look at the triad. If you are suspecting a heart, red, swollen lower limb in a patient suspected with diabetes, as a matter of fact, diabetic patients, they present with this clinical history. I came home after a long walk, slept well at home, got up in the morning, had a hot, swollen, red foot. I'm not able to wear my shoes properly. I went on a long walk. I slipped my ankle. My ankle is hurting. It's hard, red, and swollen. And that's how I'm presenting with diabetic Charcot. This is the clinical history. So when you have this clinical history, take a bit of deep discrimination, debrief details about the diabetic history in this patient, rather than do the relevant blood investigations to confirm the inflammatory markers are not raised. And please plan for an MRI scan at the earliest, because X-rays to come to the diagnosis of an early Charcot, it takes about 30% of the bone to be lost, and probably you'll be losing your time. So an MR scan is going to diagnose it much earlier than the regular X-rays.
Any questions further? Okay. Thank you so much, Dr. Prashant. I request Dr. Sanjay to give a small memento to Dr. Prashant. One of the very few surgeons who actually operates on a hot Charcot, active Charcot. So a brave heart. We can call him a brave heart because none of the orthopedic surgeons would, in India as of now, very few of them actually do operate on a hot Charcot. Thank you, sir. With that, we come to the end, and it's my duty now for giving the vote of thanks. Before I forget, this would not have been possible without the delegates. So a big round of applause for everyone who have been sitting through the day, listening to us talk about preventing amputation, talk about raising awareness, and yes, most important of all, how to make sure that patients do not lose their limb. I will not be doing justice if I don't thank Dr. Ravi, my director, who had given me a free hand over these last 20 days to make this possible. Dr. Suman from KRSSDI for all the support, Dr. APS Suri, Dr. Maya, our president, and all the delegates, Department of Podiatry staff, a big round of applause because these guys have been working day in, day out. Please come up, please come up. They have been working day in, day out, including all our podiatric nurses, all the department, including the housekeeping staff, everyone from the Department of Podiatry have been working non-stop for the last 15 days to make this a possibility. So I really think they deserve a big round of applause. Thank you one and all. Because it's only the team that makes the leader. The leader is no one if they don't have a proper team. So I have been lucky enough to have a team which has supported me wholeheartedly through this whole endeavor over the last 15 to 20 days. They have stayed back for a longer time other than their duty days. They have worked non-stop, going to the market, getting stuff that I wanted for the for all these things. So it's a real privilege. And working with them for the past 8.5 years, I will say that I have improved. I don't know about them, but I have improved. So thank you one and all. Thank you so much. Can we have a snap? Thank you so much. Now coming to the other staff, Dharmendra and his team, Bhagyalakshmi and his team. So whatever cleaning and housekeeping that you are seeing, which is allowing us to sit here, yes, that is because of them. The caterers, all the sponsors. Now I request, because see, all the sponsors once again have helped in their own little way. It might be sponsoring something, it might be helping us taking care of the travel, it might be helping us taking care of the delegate kits. But yes, even without this support, this would not have been possible. So can I ask a big round of applause for our sponsors, please? Thank you so much. Really means a lot to us. Can we have all the mementos? I will be calling the names of the sponsors. I will request one from each company to come and collect a small memento from the Department of Podiatry. Sanjay, you will do the honors. Bunny, quick. At AOIT, Mr. Sahu. Autoboc. Anamay Biotech. Someone from Anamay? Mr. Chandrish, someone is there? Yeah. Uh, 365 Medical. Torrent Pharma. JB Chemicals. Is someone there from JB Chemicals? Wellbiome Probiotics. Mayo Healthcare. Mayo Healthcare. Yostra. Lupin. Someone from Lupin here? Aeon Medicals. Arux Pharmaceuticals. KCI. Metabolica Life Care. Biocomposites. Urgo Medical. Anthem Biopharma. Urgo first. Yeah. Anthem Biopharma. A special thanks to Ravi because he took care of all the coordination with the travel for most of our speakers. Diabetic Foot Care India. Sun Pharma. Primus Remedies. Bioinfinity. Bioinfinity. Okay, before I forgot to mention a special thanks to Medinit. This is the company which has made all this possible. The coordination with the AV, getting everyone online, getting them to speak, record. Thank you so much, Medinit. Can someone come from Medinit? Nishant? And last but not the least, Food Secure.
It's not last but not the least. I have the last one this yet. Can we have a great applause for Dr. Pawan, who single-handedly organized this? Hit it! Hit it! Hit it! Thank you, Dr. Pawan.
I will say this again. I mean, there cannot be a leader without the team. It was the team, and because of the team, this was possible. Thank you, one and all. It has been a pleasure. Looking forward to this support even in the future. Thank you so much. Thank you, everyone. Till we meet again, I hope that we have been able to take some message from here. If we can, as Dr. Maya said, if we are able to save one limb after listening to the day-long program, I think my work has been done successfully. Thank you. Thank you so much.
ಹೇಳಿಲ್ವಾ ಸರ್? ನೋಡ್ಕೊಂಬಿಡಿ ಸರ್ ಒಂದ್ಸತಿ. ಗೊತ್ತಿಲ್ಲ ಅಂದ್ರೆ ಒಂದು ಎತ್ಕೊಂಡ್ಬಿಡ್ತೀನಿ ಬಿಡಿ ಸರ್. ನೀವು ಕೇಬಲ್ ಮಾತ್ರ ಕೊಟ್ಟಿದ್ದು.